Welcome to Postpartum Physiology and Assessment. My name is Ashley Danker, and I am a clinical nurse educator in the Outreach Department of Methodist Women's Hospital. I just wanted to share a tiny bit with you about myself and my experience, and then we'll get started. So, I am very passionate about maternal newborn care. I'm a mother of four, and so I experienced firsthand the impact that nurses make during such a special time and monumental time in a woman's life. This really fueled my enthusiasm for postpartum nursing and my desire to make a positive difference in a family's birth story through my own patient care delivery and through educating others. I'm an advocate of breastfeeding, perinatal mental health, perinatal bereavement, and physiologic birth, and I am dedicated to preventing maternal mortality through evidence-based education and practice, supporting new mothers and families during the perinatal period, and collaborating with the multidisciplinary healthcare team. I'm really thankful that you joined me in learning more about the postpartum patient. I hope this content helps you in your nursing practice to improve the care you deliver, to sharpen your assessment skills, to strengthen the education that you provide, and to make a positive influence on the families you care for after birth. During this program, we are going to discuss the normal physiologic changes of pregnancy and postpartum, not all, but many. We'll identify essential components of a comprehensive postpartum maternal assessment and recall critical postpartum discharge education points you should be teaching your patient and their families. So when we talk about the postpartum period or the puerperium, this is the time period that begins immediately after birth. Traditionally, the time frame for the postpartum period was about 6 weeks. However, the time frame really varies among individuals. Currently, research shows that this period can continue for about 6 to 12 weeks after delivery, or it may last even longer than that. Additionally, some changes or stressors that occur during pregnancy and postpartum, those can last up to 12 months or longer. So our patients do require more attentive care and close monitoring during this time period. If you've heard the term fourth trimester, then you would be familiar with this already, but this is the term that refers to the first 3 months postpartum. This term helps emphasize the equal, if not greater, importance of the postpartum period, in addition to the first, second, and third trimesters of pregnancy. So throughout this program, we're going to discuss the changes that happen physiologically during pregnancy and compare those to the postpartum period. We'll talk about what to assess for with your patients, nursing interventions that are specific for each system, and critical discharge education related to that system. The average length of stay for a new mother and baby in the United States is 1 to 2 days. It's not very long. Some patients choose to discharge even sooner than that, in as few as 6 hours, depending on their delivery location and the facility, et cetera. There is an abundance of information that needs to be communicated to families before discharge. Education is a huge piece of postpartum nursing. A lot of this education focuses on important signs and symptoms to watch for in themselves and in their babies, and when to call providers if these concerning signs and symptoms occur. Over 50% of maternal deaths occur during the postpartum period after discharge from the hospital, which emphasizes how critical it is that families know when to call their provider and when to seek help before it's too late. As we talk through many of the physiologic changes that occur during the postpartum period and what to teach families, think about how you can incorporate this education early on in the postpartum period and reinforce it often before discharge. ACOG recommends that discharge planning and education begin during pregnancy. Now, as a postpartum nurse, we don't have the luxury of incorporating discharge planning during pregnancy. So starting early in that postpartum period and reinforcing multiple times is even more important. In addition to providing education, as a postpartum nurse, your role is to assess for deviations from the normal postpartum physiology, to relieve discomfort and pain, to provide safety measures to prevent injury and infection, and provide nurturing support and encouragement to new parents as they navigate caring for themselves and their infants. A1, which is the Association of Women's Health Obstetric and Neonatal Nurses, recommends that newly delivered patients spend 2 hours or more if needed in labor and delivery with one-on-one care after birth. This immediate postpartum period is really critical for the entire dyad, and it's essential to monitor for complications that may occur. Our patients are really fragile in those first 2 hours after delivery, and we'll talk about the risk of cardiac decompensation and the risk of hemorrhage, in addition to other complications. But those two specifically stand out to me as they are at heightened risk in those first 2 hours after delivery. So this one-on-one care is really important. After the 2-hour recovery time period, when your patient is initially determined to be stable, they typically will be transferred to postpartum care. So whether you're in an LDRP unit and you're transitioning to postpartum care, but still in the same room, that may happen, or you may work in a facility that has a separate labor and delivery and postpartum units. And so you may be participating in bedside report when your patient's transferred from labor and delivery or the recovery room to the postpartum unit. Either way, it's important as the postpartum nurse to be aware of essential information that comes from admission, from birth, and from the recovery time period that will be helpful to you as you assess and care for your patient and determine if risk factors are present, if there's a risk for certain complications for your patient, any specific and special interventions that would be required, etc. This is the list that kind of gives some examples of that essential information that you need to know as the postpartum nurse. Okay, and starting our assessment discussion, we'll look first at the reproductive system. So we'll talk about the uterus, the cervix, ovaries, vagina, perineum, pelvic muscular support, and then breasts. So during pregnancy, the uterus in pregnancy, growth is initially stimulated by increase in estrogen and progesterone, increased vascularity and dilation of blood vessels, in addition to enlargement of and production of muscle fibers and fibroelastic tissue and development of the decidua. After the first trimester, uterine growth is primarily done by mechanical distension of the uterus from that growing baby. Oxygen consumption significantly increases during pregnancy and in the uterus in order to meet the demands of the fetus, and it's usually highest in the third trimester when that fetal growth is accelerated the most. Lastly, blood flow increases to about 10 times over the pregnancy course. Um, 1/6 of the total maternal blood volume is contained within uterine vasculature, which is why an increase in circulatory volume is needed. And we'll discuss that in more detail in the cardiac section. Hypertension, IUGR, or intrauterine growth restriction, diabetes, and multiple gestations are all things that can increase the risk for decreased placental perfusion during pregnancy. Increased estrogen and progesterone levels stimulate the growth of the uterus during pregnancy, and it can grow up to about 11 times its non-pregnant weight. Uterine growth occurs from an increase in uterine muscles. We call this hyperplasia, and by enlargement of the existing muscles, which is called hypertrophy. So the decrease in these two hormones, estrogen and progesterone, result in an autolysis that occurs in the postpartum period. This time, the autolysis is the self-destruction of excess uterine tissue that developed during pregnancy. So any of that new tissue, the excess tissue that was developed during pregnancy is destroyed during the postpartum time period. And then there are new cells that were developed during pregnancy. Those will remain in addition to the existing cells, but they will decrease in size. So that increase in uterine cells will actually account for a slight increase in the size of that uterus after each pregnancy. So it doesn't always go back to its exact pre-pregnant state, but it does get close. Patients will experience contractions, and we want them to experience contractions in the postpartum time period. This helps compress the intramyometrial blood vessels, which is what provides hemostasis to our patients in the postpartum time period and prevents hemorrhage. Contractions are typically coordinated from oxytocin. This is a hormone that strengthens and coordinates contractions. It can be found or administered, either found innately in a patient's body, which is endogenous oxytocin. So this is that hormone that oftentimes is released during breastfeeding. It's released immediately after birth if a patient's feeding right away or doing skin to skin, and it continues to be excreted in the early days after birth. to help promote contractions of that uterus. Exogenous oxytocin is medication Pitocin that we're all familiar with or should be. This is usually administered after the birth of a baby and before the placenta as part of active management of the third stage of labor. It's also our primary or our first line intervention for postpartum hemorrhage. After pains are the contractions or the cramping that occurs after delivery when that uterus is clamping down or contracting to go back to its normal size and to provide hemostasis to that patient. They're usually intensified by breastfeeding and Pitocin because of that increase in oxytocin production or administration. They're typically more intense for patients that have had multiple babies. So our first-time moms or our primips, they often will complain of mild to no contracting. And that's usually related to their good muscle tone. Their fundus typically doesn't have complications with remaining firm. And they haven't had that uterus hasn't been stretched out multiple times with multiple pregnancies. However, with a multip patient, they experience more periodic periods of relaxation and then vigorous contracting. And so that can cause some more painful cramping for these patients. It can be pretty common. You can encourage them that it lasts about 3 to 7 days. So by about a week postpartum, usually that resolves. And then in the meantime, if they're experiencing those intense cramping, doing interventions, we'll talk about these more later, but some interventions like heat, applying heat while they're breastfeeding or heat when their uterus is cramping can be really effective in addition to maintaining an empty bladder. Uterine involution, this is the return of the uterus to a non-pregnant state after birth. It begins immediately after delivery of the placenta with contraction of the uterine muscle. Right after delivery, immediately after delivery, the uterus is about 2 centimeters or 2 finger breadths below the umbilicus, and that's depicted in level A in this picture. About 12 hours after delivery, by that time period, the uterus relaxes a little bit, that muscle relaxes slightly, and that level rises to about 1 centimeter or 1 finger breadth above the umbilicus. By 24 hours postpartum, the fundus is about the level of the umbilicus or U/U, and it will continue to descend by about 1 finger breadth or about 1 to 2 centimeters every 24 hours each day. So really, if you remember anything, the theme of your fundal assessment should be lower in height. Anytime you have an increase in height of that fundus, that should be a red flag to you that that uterus is not contracted like it's supposed to. It has relaxed, potentially filling with blood or clots, and needs to be assessed or intervened. Also, uterine location can be affected by the bladder. So if that bladder is distended, what it does is it pushes that uterus or that fundus up and over to the left or to the right. And so if it's increasing in height too, it could be from a full bladder too. So having your patients empty frequently is important. The uterus should not be palpable abdominally by about 2 weeks postpartum, and it completely returns to its pre-pregnant location by 6 weeks postpartum. Uterine size and involution are influenced by if the patient is a multip, if they've had multiple babies, multiple gestation with this pregnancy. Do they have any overdistension of the uterus from uterine fibroids, polyhydramnios, multiple babies, a large baby, and then if that bladder is descended as well. Subinvolution, this is the failure of the uterus to return to non-pregnant size and function due to ineffective uterine contractions. Most common causes of this are retained placental fragments and infection. It usually will present as late postpartum bleeding, so after discharge or prolonged lochia discharge, irregular or excessive bleeding. Sometimes it can look like a significant hemorrhage, but a lot of times it's more of that late continued, that late bleeding that's continued after discharge. And then if a patient were to come back in to be seen by a provider upon pelvic examination, the uterus is typically larger than expected and it's boggy. So it's not been able to go back to its pre-pregnant state. When you're doing your uterine assessment, you want to assess for consistency, tone, position, height, and tenderness. So a normal fundus would be one that is firm, that is midline, that is at the level of the umbilicus or below typically. But do remember that the fundal height is about 2 centimeters below the umbilicus immediately after delivery. It rises to about 1 centimeter above the umbilicus 6 to 12 hours after delivery, and then it continues to go down after that time period. But generally speaking, at the level of the umbilicus or below would be appropriate. Any lateral deviation that your patients may have in their uterine assessment and location can indicate bladder distension. Other abnormal findings would be if the uterus is soft, if it's boggy, and if it's higher than expected. If you do an assessment and you do find a boggy uterus, you want to make sure that you massage it until it's firm. And then note that if it continues to become boggy, that you would notify the provider to have them do further assessments. Typically, you'll see an increase in lochia, increase in bleeding, other risk factors or other signs and symptoms in addition to a boggy uterus. But sometimes if you catch it early, massaging until it's firm is effective. It can just is enough to stimulate that uterus to contract. Maintaining uterine tone and preventing bladder distension will help prevent excess bleeding. If the uterus has poor tone, it will fill with blood and clots, which will impede placental site vessels from clamping off, and it can result in hemorrhage for your patients. When you're doing a uterine assessment or you're doing any fundal massage, you want to make sure that you're using both of your hands to assess and massage your patient, just like the picture is shown here. You'll use one hand to cup the top of the fundus and do your massage at that spot, and the other hand will support the uterus by the symphysis pubis to help prevent uterine prolapse. If your fundal assessment shows a boggy uterus, like I mentioned, you're going to gently massage the fundus until it feels firm. Massage is what stimulates that uterine muscle to contract. It restores muscle tone and it helps prevent hemorrhage. So usually this is your first line intervention. You also should be aware that fundal massage can cause short-term increase in vaginal bleeding and our clots that are expelled. It really isn't a massage, so I don't know why they use that term, but it's actually quite uncomfortable, unlike its name. So I always try and explain to my patients why I'm performing fundal massage, what it will feel like, that it can be uncomfortable. It's not, relaxing by any means, and that taking deep breaths during the assessment can help with discomfort while I'm doing that massage and stimulation of the uterine muscle. Other things to note when you're doing your uterine assessment or interventions that you might do. One, you need to know your patient's baseline. So it's really important to determine where was that fundus at before you assessed it, or when the nurse before you assessed last time. It may be helpful to pre-medicate your patient with routine scheduled medications, especially if they were a scheduled cesarean section and they have an incision. They may have guarding of those abdominal muscles, and that can be a little bit harder to assess that fundus. You want to ensure that your patient has voided before assessment. Again, remember that a full bladder or bladder distension can change your fundal assessment and findings. It can also increase the risk for uterine atony and hemorrhage. So having them empty their bladder before you do your assessment is really effective. You want to make sure you're assessing lochia with each fundal check. We'll talk about lochia here in the next section. So just parking lot that for a minute. Assess for after pains and provide interventions as needed, and then chart appropriately. So again, making sure you're charting your full uterine assessment. So its location, if it's midline, if it was boggy or firm, and if massage was needed to stimulate the uterus to contract. After delivery of the placenta and membranes, vascular constriction and thromboses decrease that placental diameter, which is the area where the placenta was attached during pregnancy. The upward growth pattern of the endometrium causes sloughing of necrotic tissue at the placental site, and it helps prevent scar formation, which allows the endometrium to resume its cycle of changes that we normally see pre-pregnancy and in a non-pregnant state, and to allow processes necessary for future pregnancies. Endometrial regeneration begins about 3 days postpartum, and it's complete by about 6 weeks postpartum. Lochia, this is the postpartum discharge that's associated with uterine involution and those endometrial changes that I talked about on the previous slide. It can last about 4 to 6 weeks or longer postpartum, and it occurs in 3 different stages. So stage 1 is rubra, which is when the lochia is typically bright red. It lasts about 1 to 3 days postpartum. And that transitions to serosa, which is about like a pinkish brownish tinge. It's definitely not the bright red discharge. And this can last about 4 to 10 days postpartum. And then that progresses to alba, which is a whitish yellowish discharge and can last about 10 to 14 days, or even as long as 3 to 6 weeks, depending on your patient. The different contents that are included and the type of lochia are listed on here for you as well, if that's interesting to you. Lochia has a musty, stale, definitely a unique odor that should not be offensive. So any foul smelling or odor would be a sign of infection that you would need to report to the provider or teach your patient to report to the provider. Usually, initially, the volume is the amount of approximately what your patient's heaviest menstrual period would be for about the first 2 hours after delivery. And then it should steadily decrease in amount and change in characteristics over the postpartum time period. In terms of volume for lochia, we should always be trending, and color. The volume and the color should always be trending towards lighter flow, lighter in color. And this is what I'm watching for as the postpartum nurse and what I'm teaching my patients to watch for when they go home. If your patient received oxytocin, lochia flow is usually scant until the medication wears off. So that's just something to note in the immediate postpartum period. Most of our patients do receive oxytocin for active management of the 3rd stage of labor. So it is very common that flow will be scant until that medication wears off, and then it will increase a little bit in volume to be more of a physiologic, normal volume. Volume is usually less after a cesarean birth compared with a vaginal delivery, and this is due to the suctioning of the blood and fluids from the uterus before closing that incision. Flow typically increases with ambulation and breastfeeding, so preparing your patients for this and teaching them that can be really important. Lochia also tends to pool in the vagina when the patient's lying in bed, and so she may experience a gush of blood when she stands up. It's important to consider so as not to confuse it with hemorrhage. And then at 7 to 10 days, or excuse me, 7 to 14 days postpartum, it's not uncommon for a patient to experience a brief sudden increase in bleeding, and in bright red bleeding specifically, when sloughing of the eschars over the placenta site where that area has been healing occurs. So if you think of that, it's not a scab, but I kind of explain this to patients. Like there's like growth of tissue and healing tissue, kind of like a scab that develops over that area where your placenta has been attached in the uterus. Some patients, not all, at about 1 to 2 weeks postpartum will experience a tiny bit or small increase in bright red bleeding or recurrence of bright red bleeding when that scab comes off. And so teaching them that that bleeding only, it's short term. It lasts for, an hour or so. If it continues to bleed heavy or bright red after an hour to 2 hours, they need to call their provider to be assessed for retained placental fragments. Warning signs for lochia include general persistence of bright red lochia in the postpartum period, which can be indicative of subinvolution, usually by retained placental fragments. Another warning sign would be persistent flow of lochia serosa or alba by 3 to 4 weeks postpartum, especially if it's associated with fever, pain or abdominal tenderness, and offensive lochia odor. We're thinking endometritis or some infection inside the uterus at that point. And then another thing to note is not all vaginal bleeding is lochia. So some vaginal bleeding can occur from maybe an unrepaired laceration, whether it's in the vagina or the cervix. And so it's important to be able to distinguish between lochia and non-lochia bleeding to determine the cause and respond appropriately. And there's a table on this slide that will kind of help you compare those two and hopefully give you some guidance to distinguish the two. The biggest difference is check the uterus, because if it is lochia that is causing an increase in bleeding, typically your fundus is going to be boggy. It's not going to be firm. That uterus won't be contracted, and so it's going to cause that relaxation of the muscle will cause an increase in lochia. Whereas if it is a laceration that is the problem, that uterus will contract normal. It'll be nice and firm. It'll be contracted because it's doing its job. And so that's how you'll know that that bleeding is coming from an alternative source, like an unrepaired laceration. Lochia is usually described in volume amounts such as scant, small, moderate, or heavy. You also may hear excessive as well. Excessive is when your patient is bleeding or saturating a pad in 15 minutes or less. In addition to pooling of blood, sometimes under the buttocks, which can be seen also and is a sign of hemorrhage and requires immediate assessment, treatment, and notification of the OB provider. When lochia is initially assessed by observation, but in any circumstance when bleeding is concerning or questionable, use your quantification of blood loss by weighing saturated items and by weighing clots. This is much more accurate. So when you're assessing lochia, it's really important, especially if you're not sure if it's too heavy or not, or you're not sure, you're starting to see maybe a trend of a little bit like a constant trickle, or maybe your patient just has moderate flow, but consistently every time. You can always weigh that and add it together and to check for cumulative blood loss over time. That's totally fine, and that would be appropriate in evidence-based practice. It also helps with getting a provider to the bedside too. Whereas if you don't have a huge gush of blood, if you're not having a huge increase in volume, an immediate obvious hemorrhage, but you're still concerned about your patient, having that volume that's cumulative to provide to a provider can be really helpful in getting them at the bedside to help you. Also, when you're assessing lochia, don't forget to consider the time frame in which the bleeding occurred. So how long has it been since your patient has changed her peri-pad? Maybe it looks like it's a heavy flow or heavy lochia, but it's been 6 hours since she changed her pad. So I always ask those things when I go do my assessment. When was the last time you got up to the bathroom? When was the last time you changed your peri-pad? Just so I have an idea, time frame of how long it's been since that lochia has accumulated. Other thing to consider too would be the brand of the pad or the type of the pad that's used, because it can cause variation in volume absorbed and the appearance of um, if it's soaked or not. And so especially if your patient is using a crackable cold pack, those are really not absorbent and they can leak very often. So paying attention to those and just being aware of their absorbency and what they may look like when they're saturated or not can be helpful. But again, if there's any question or any concern, quantifying and weighing will give you the most accurate answer. So always err on the side of caution and weigh if you need to. A gush of blood when standing, when your patient gets up for the first time, is pretty normal. It's normal for pooling of the blood to occur in the vagina when a patient's lying down. Think of gravity. And so when they stand up, that gravity causes the lochia flow when the patient is upright. It certainly should not be continuous, but you might have an initial gush that resolves on its own. Passing clots can be normal as the blood that pools while the patient's lying down naturally clots. So again, it would be a short term or a one-off occurrence and not continual clots that your patient's passing over time. Frequent OB assessments performed during the postpartum period are really helpful. They help you provide prompt identification of excessive bleeding. They help you know when you need to start weighing. They help you know when you need to notify a provider. And it is really important that you accurately assess the fundus and lochia while your patient's in the hospital. So lochia, when you're doing your assessment, you're assessing for character, the clots, the amount, the odor. Normal findings would be if they have scant to moderate flow, if they have small clots, less than a nickel size or so. Depending on the literature, sometimes you'll hear less than plum size, less than egg size, just depends on the text that you're reading. And then a non-offensive odor. Abnormal findings would be if your patient has heavy lochia, large clots, many clots, uterine actiny, a foul-smelling odor, etc. And we talked about those common concerns on the previous slide, so I will skip that. When you're providing education on lochia, you want to educate your patients on the normal lochia progression, sloughing of the placenta site, when that may occur and what it would look like. And you need to teach them on when to call their healthcare provider, which includes if they're saturating a pad an hour or less, if they're passing clots egg size or plum size or larger, if they have a return of bright red lochia after previously stopped, after that bright red had previously stopped, and if they have persistence of bright red lochia that occurs once they're home, in addition to foul-smelling odor. There are a lot of other reproductive changes that occur during pregnancy and in the postpartum period. I have some related to the ovaries and the vagina that are listed here for you to review, but for time's sake, I'm just going to emphasize the ones that occur during with the breast changes. So during pregnancy, breasts are prepared for lactation and progressively grow in size during pregnancy. Early on, estrogen stimulates growth and an increase in lactiferous ducts, which are our milk ducts, and progesterone stimulates growth and development of mammary lobes. Prolactin, progesterone, and human placental lactogen all stimulate the development of lactocytes, the cells that produce colostrum and mature milk. Prolactin stimulates production of colostrum by the end of the first trimester. During pregnancy, lactogenesis 1 occurs. This is when colostrum stimulated by prolactin is produced by the end of the first trimester, and then it's excreted during the second trimester. Here are changes related to cervix, ovaries, and menstruation that occur in the postpartum period. Again, I'm going to let you kind of review these on your own for time's sake, but they are here for you to review. One thing that I wanted to highlight in this section is that postpartum estrogen deficiency can result in thin vaginal mucosa. And especially for patients that are breastfeeding. So when you're doing your postpartum discharge education, teaching them on the risk for vaginal dryness, especially when they resume sexual activity, is really important. And they may need to use some lubrication to help with that until their estrogen increases once breastfeeding has stopped. Another thing that's on this slide too that's important to note is that the initial healing of a laceration or episiotomy can occur within about 2 to 3 weeks after delivery, but it really takes a complete 4 to 6 months for total healing to occur. So it's really important that a patient goes to her postpartum visit and has a provider do an assessment to check for healing and to provide more individualized guidance on when to resume sexual activity to not impair or impede with that healing process that needs to occur. When you're doing your assessment of the perineum and the rectum, you want to inspect for the presence of lacerations, episiotomies, and hemorrhoids. You'll do this. The best way to do this is by placing the patient in a lateral Sims position, so having them lay on their side. Then you can lift their buttocks, expose the perineum and their anus, and check for hemorrhoids, etc. It also is really helpful to do this too, to assess for bleeding. Like when I mentioned to check for lochia, not only do we look at the pads, but sometimes excess lochia, especially if a patient's hemorrhaging, it can be very deceiving and leak past the pad and down under their buttocks onto their chucks pad. And so doing an accurate assessment by turning the patient onto their side will help you observe for hidden bleeding or lochia that has collected on that chucks pad underneath them. You'll be surprised how many patients will have hemorrhoids that they didn't realize they had during pregnancy. And a lot of times during pregnancy, hemorrhoids develop, but they're internal. And then when patients are pushing, it causes those to push externally, and then they'll experience signs and symptoms postpartum. So do your good job of assessing, turn your patient on their side, do your full assessment. It's really important. Thankfully, episiotomies are not very common. They're only used in approximately 10% or less of US births. And really, they're not evidence-based practice, which is why we advise against them. But there are some complications that you should be aware of if your patient did receive an episiotomy. The first is that they can have an increased frequency of 3rd and 4th degree lacerations. So assessing for that, assessing for healing is important. Assess for an increase in infection because they have increased risk of infection. They also have increased risk of pain and delayed healing over time. So doing a good job of assessing those would be helpful for your patient. This is a slide that just shows the different types of lacerations that may occur, excuse me, in your patients. They can have a 1st, a 2nd, a 3rd, 4th degree lacerations. They can also have a cervical laceration. The most common are 1st and 2nd degrees. The 1st degree is a laceration that goes through the perineal skin and mucous membranes. A 2nd degree is a laceration that involves the skin, mucous membranes, plus the fascia and muscles of the perineum. 3rd degree involves the skin, mucous membranes, muscles of the perineum, and it extends to the rectal sphincter. And then lastly, 4th degree extends through the anterior rectal mucosa, exposing the rectal lumen. When you're doing perineal and rectum nursing care, you want to assess for healing. So using your RETA, if you've heard of that, that's a kind of an acronym to assess for wound healing, which includes looking at redness, ecchymosis, edema, discharge, and approximation. You want to make sure that you're doing a good job assessing for pain, assessing hemorrhoids. Do they have any? Are they present? If so, how many do they have? What is their size? Do they have any pain or tenderness associated with that? You also should know that excessive postpartum bleeding can also occur from the vagina or from vulvar hematomas or unrepaired lacerations of the vagina and the cervix. And so you can suspect that an unrepaired laceration maybe is the cause of bleeding if the fundus is firm, if that muscle is contracted, but excess bleeding or constant trickle of blood remains. So that's something to be aware of too when you're doing your perineal assessment. Expected findings for your patient would be to have their perineum have minimal edema, for it to be soft. If they do have minimal to moderate pain, that it would be controlled by analgesics and non-pharmacological techniques or both. If you are suspecting if your patient has a lot of edema in their perineum, letting them know or asking if it's okay if you gently palpate can be helpful to determine if you, especially if you suspect that a hematoma is developing. If it is edematous but soft, it's typically just from the trauma from delivery, can be treated with ice. However, if it is edematous and firm, that's usually a sign of a hematoma. And oftentimes it will be associated with pronounced edema, bruising, and intense pain that's not relieved with the medications, the non-pharmacologic interventions. And patients that have a hematoma too usually have a really hard time sitting still. I mean, they are just so uncomfortable. They cannot sit still. They cannot find comfort, and that would be a red flag for you to watch for too. Non-pharmacological interventions to promote comfort for your patients with their perineum and their rectal area would be to use dermoplast spray, ice diapers, sitz baths can be really soothing, use of tucks for both perineal irritation and inflammation and for hemorrhoids. You can use it for either one. Is really effective. Repositioning, so having patients not necessarily sit straight up and down, but having them kind of sit off to the side or lay on their side, using stool softeners or laxatives, high fiber diet and hydration to prevent constipation. Use of peri-bottle, that warm water can be really soothing, to rinse before voiding, after voiding, to help with voiding, and then teaching patients to pat that area dry. We also want to teach them good infection prevention techniques. So this includes hand and perineal hygiene. Again, that peri-bottle use, changing their pad with each void or at least every 4 hours, and patting dry will help decrease that risk of infection. It would be helpful to avoid using a donut pillow. While they seem like they may be helpful or soothing, that small ring that is meant to decrease pressure on the perineum, it actually causes pressure around where that ring is and decreases blood flow, which can delay healing. So avoiding those would be helpful. And then if your patient is experiencing extreme pain, especially after receiving pain medication in their perineal area, I would be suspicious of a hematoma or infection and do further investigation. Changes that you might see with breast in your postpartum patient are listed here. Shortly after birth, the hormones responsible for breast development during pregnancy decrease, and the time when these hormones return to pre-pregnancy levels is generally affected by breastfeeding. Little changes are noted in the first 24 hours or so postpartum. Colostrum can be expressed from the breast right at birth because we know it can be expressed during pregnancy, so it should be available and able to be expressed at birth too. Lactogenesis 2 occurs around 72 to 96 hours postpartum, and this is that transition from colostrum to copious milk production. So patients, their breasts will feel fuller, they will feel heavier. Sometimes that transition, as that milk production increases, breasts can be warm, firm, or tender. They can have some edema. They may feel nodular or lumpy upon palpation, and these are usually transient findings that will go away on their own as long as the patient is feeding on demand, doing frequent skin to skin, and rooming in with their babies so that they can feed as often on demand as needed. Patients may experience engorgement, which can last for 24 to 48 hours in a breastfeeding patient who is feeding her baby on demand. This is usually a result of increased blood and lymphatic fluids as well as milk production. So it's kind of a duplicate. It's both things that are causing that engorgement. Engorged breasts are hard, they're uncomfortable. Patients may have a mild temp elevation, does not mean that they have an infection all the time. That's just from that inflammation that's occurring. And full or flattening of the breasts can flatten that nipple and make it challenging for the baby to latch or feed. So getting lactation involved can be really helpful for you as the bedside nurse if you have that option. Prevention, though, is key. So remember, encouraging rooming in, frequent skin to skin, on demand feeding is what has been shown to help prevent engorgement. For your patients that are not breastfeeding, their breasts often feel nodular bilaterally. Their prolactin levels will drop rapidly in the postpartum period. They still can have colostrum in those first few days postpartum. They still experience breast tenderness that occurs about 2 to 3 days postpartum. They still will have milk present, but we want to encourage them not to express it if their goal is to not breastfeed. And they also may have engorgement, about 2, 3 to 4 days postpartum, which usually resolves in about 24 hours. When you're doing a breast assessment, you want to assess the breast for size and shape. Any abnormalities? Do they have any reddened areas? Are they engorged? Are their nipples intact? Do they have any trauma in that nipple area, such as redness, bruising, cracks, fissures, abrasions, blisters? All of these would be associated with latch difficulties. So that's going to be your first thing that you're going to assess is the latch, or get someone that is a specialty in lactation to assess that latch with you, or in addition to your assessment. It can be tricky to know if your patient's experiencing breast fullness or engorgement. And so this comparison table by Davidson and colleagues is really helpful for me. Either way, the prevention, they're typically both transient as long as the baby is feeding on demand. I can't emphasize this enough. So on-demand feeding, frequent skin to skin, rooming in are the things that we can do to help prevent engorgement. Breast comfort measures for patients would include, for breastfeeding mothers, are on the left here, and they would include feeding on demand, cold compresses to the breast after feeding, bags of frozen peas or corn or things like that work really well when patients are at home. They can use gentle massage, but I emphasize like so gentle, 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 like what you would touch your baby's cheek with, gentle. And hand expression to relieve pressure, just enough to relieve pressure in the breast, but not to express the full amount of milk that's possible from the breast. They can apply colostrum to their nipples if they have any trauma or discomfort, and use glycerin gel pads for comfort as well. And then NSAIDs, like the scheduled Motrin that we would give during the postpartum period, can help with reduce inflammation related to milk breast fullness and engorgement. For non-breastfeeding mothers, a lot of the interventions are similar. You want to assess for evidence of discomfort, encourage them to use cold compresses too. The NSAIDs, again, like ibuprofen, will be really helpful for these patients to reduce pain and discomfort and edema, inflammation. And then you want to teach them to avoid stimulation to their breasts and nipples. So avoid like letting the shower water run over their breasts. If they're doing skin to skin, it might be more skin to like a sports bra, or positioning maybe a little bit higher on the chest. So that way you can protect that breast area with a sports bra to decrease stimulation. You want to avoid newborn suckling and avoid expressing breast milk as well. In regards to the breast assessment, you'll educate your patient to call their healthcare provider if they have any cracked or bleeding nipples, any engorgement or hard, lumpy, reddened areas on their breasts, if they are experiencing a fever, if they have any flu-like symptoms, or aches or chills. I had some recording difficulties and challenges, so I apologize for my uh, outfit change. But we are going to continue on with the cardiovascular assessment of the postpartum patient. So in this section, we will cover blood volume, cardiac output, blood pressure, structural adaptation changes, and changes to the blood components. One thing that I really want to emphasize is that there are significant anatomic and physiologic changes that occur to the cardiovascular system during pregnancy. And so it is really important to know which changes persist during the postpartum period and which may be a sign of postpartum complications if they do not return to a non-pregnant state after delivery. And so we'll go through some of those. So during pregnancy, there is a total blood volume increase by about 40 to 50%, which is approximately 1,200 to 1,600 millimeters above non-pregnant values. This is even greater in multiple gestations, and blood vessels dilate. So what is meant to happen during pregnancy is that those blood vessels are supposed to enlarge and dilate to compensate for this increase in blood volume and to help meet perfusion demands to both mom and to the fetus. There are a couple purposes for this increase in blood volume. One purpose is to meet the blood volume needs of the hypertrophied vascular system and of the enlarged uterus. Another one is to help hydrate maternal and fetal tissues. And lastly, to compensate for blood loss during birth and postpartum. So in the postpartum period, changes in blood volume really vary depending on a variety of factors, including a patient's blood loss after delivery. So what was their quantitative blood loss? It also depends on the extravascular water or physiologic edema that is mobilized and excreted after delivery. An average blood loss for a postpartum patient at delivery for a vaginal delivery would be 300 to 500 milliliters, and for a cesarean would be 500 to 1,000 milliliters. During the first few days postpartum, diuresis initially decreases the plasma volume for a patient. And so this helps, if you think about, blood volume, and we have the red blood cells and those blood components, and then we also have part of blood volume is plasma. And so to decrease that blood volume after delivery, in addition to blood loss, that plasma needs to be removed as well. And so that is done through diuresis. For our patients, it's really important to understand that failure to diurese can lead to pulmonary edema and subsequent cardiac complications. This is more common in patients with preeclampsia or those with history of cardiac disease, but it is not not exclusive to those two. So keep an eye on your patient and really watch her eyes and nose, make sure that what's coming in is going out, in addition to the physiologic diuresing that we would expect to happen. It's just really important to watch that. Plasma volume is replenished about by the third day postpartum as extravascular fluid returns to the intravascular space. And I think I have this on a future slide, but I'll just explain it here. A lot of times when I have postpartum patients, they will have some swelling in their feet or ankles. Even sometimes their breasts can be swollen too, just depending on their medications and what risk factors they've had. And so one, Pitocin that we administer after delivery for most patients to prevent hemorrhage after delivery, so that active management of the third stage of labor, that Pitocin that's administered, that medication has a water retaining property. So if you have a patient that's had Pitocin, it would be pretty common as a side effect of that medication for them to hold on to some of that water and to diurese a little bit later until the Pitocin has been processed out of their system. Another thing that I always tell patients too is a lot of times they'll complain like, oh my goodness, my feet are so swollen. They were not like this before I came in. And so I do teach them what signs and symptoms to watch for when that edema would be abnormal. But I also teach them in just very basic terms, but after you have a baby, your body goes through a massive fluid shift to get rid of all that extra blood volume that you needed during pregnancy. And so there's fluid that is inside your blood vessels that's now moved outside the blood vessels. And that's a lot of times why we see some of that edema. And so teaching them to drink lots of water, to stay hydrated, there's little tricks and things that they can do that can help with diuresing, including adding lemon to their water. Grapefruit is a natural diuretic. So some of those things can kind of help mobilize that water a little bit faster. But typically it gets better by about the third day postpartum as that fluid that's moved to the extravascular system is now going back to the intravascular space. There are a few physiologic changes that occur in the postpartum patient, which increase circulating blood volume initially to help cope with the blood loss that occurs after delivery. And so the first one is elimination of the uteroplacental circulation. This change helps reduce the size of the maternal vascular bed by about 10 to 15% and help prevent hemorrhage and future blood loss. Second, there's a loss of placental endocrine function, which removes the stimulus for vasodilation. So remember, during pregnancy, those blood vessels have to dilate to help compensate for the increase in blood volume and the needs of perfusion for both mom and baby. In the postpartum period, the endocrine function for that is removed, and so those vessels can now constrict again, which helps cope with that decrease in circulatory blood volume. And then lastly, there's mobilization of the extravascular water stored during pregnancy from inside the vessels to outside the vessels, like I mentioned earlier, and that helps compensate as well. And then after a couple days, about day 3 postpartum, some of that fluid that remains will move back to the intravascular space. So during pregnancy, cardiac output changes significantly. So it increases about 30 to 50% during pregnancy. And by about 25 to 30 weeks gestation is where it's at that peak. It'll decline to 20% by about a 20% increase by about 40 weeks gestation. Either way, important to know that cardiac output is increased in postpartum patients right after delivery because it's been increased during their pregnancy. So just something to remember. There also can be an increase in heart rate, which peaks at about 15 to 20 beats per minute over their pre-pregnancy baseline. And that can persist until term as well. There is an increase in a result of increased stroke volume and increased heart rate. And that occurs in response to increased oxygen demands in the tissues. And then cardiac output further increases, this increases further with exertion from labor and from delivery. So I always try and think, or when I teach or teach patients too, but I always try and think of, delivery, it's like a pregnancy in general and delivery on top of that. That's like an exercise or an increased workload on the heart. Like you've done this massive exercise, you put all this exertion on the heart. It's a huge stressor. And if we don't watch our patients carefully, especially those that have risk factors, we can miss some early signs of decompensation. So in contrast to the changes that happen in cardiac output during pregnancy, in the postpartum period, immediate blood loss decreases the plasma volume without reducing the cardiac output. Approximately 500 milliliters of blood immediately after delivery is diverted from the uteroplacental system into the maternal circulation. There's a rapid decrease in uterine blood flow after delivery, and then, like I mentioned, that mobilization of the extracellular fluid. Cardiac output will peak immediately after birth by 60 to 80% above pre-labor values. And so this drastic change, in addition to changes to pulse rate, to stroke volume, and cardiac output combined, that drastic change in the immediate postpartum period can result in cardiovascular instability if our patients are not able to compensate appropriately. Now, cardiac output it should return to pre-labor values by about an hour postpartum, and then it declines by 30% by about 2 weeks postpartum. It takes 6 to 12 weeks for it to return to its non-pregnant level. Blood pressure changes in pregnancy. There's not really a ton that occur, actually. Blood pressure remains mostly the same or slightly decreased from the reduced systemic vascular resistance that occurs during pregnancy. So that dilation of those blood vessels so that the mom and baby can perfuse, those organs can be perfused. There are some influencing factors on blood pressure, including pregnancy, age, the activity level, comorbidities, circadian rhythm, alcohol intake, if the patient's a smoker, they have anxiety, if they're in pain, what maternal position are they sitting or resting in. So some of those things can influence blood pressure significantly, but generally speaking, for patients that don't have any risk factors or don't have any influencing factors, their blood pressure remains mostly the same. There is an increase in venous pressure and reduced blood flow in the legs that occurs during pregnancy, and that's from that pressure of the uterus on venous return, especially at the end of pregnancy as it is enlarged. This can result in dependent edema. It can result in varicose veins in the legs and the vulva and hemorrhoids as well. All of these increase your patient's risk of VTE in the postpartum period. This does regress rapidly after birth. Total regression is expected in the postpartum period, but sometimes varicose veins can persist longer throughout a patient's life. There's also structural changes that occur during pregnancy. So the heart changes in size and position. There's slight cardiac hypertrophy or enlargement of the heart that occurs as a result of that increased blood volume and cardiac output needs. The heart is pushed upward and forward to the left due to that enlarged uterus pushing on the diaphragm. There can be transient oscillatory changes that occur from alterations in the heart size and its position, its blood volume, and its cardiac output. And sometimes these can result in a third heart sound that's audible during pregnancy and immediately postpartum. It's transient typically, but you may hear it when you're listening to your patient's heart sounds after delivery. Cardiac rhythm is affected, and as a result, patients with pre-existing heart disease, they really need to be monitored closely during pregnancy and in the immediate postpartum period, especially because they are at risk, increased risk for arrhythmias during labor and delivery. And that immediate time period when cardiac output is significantly increased. Blood components that change during pregnancy. So there is a physiologic anemia pregnancy that occurs, and we talked about a little bit earlier the increase in plasma volume and red blood cells because of that increase in blood volume that happens during pregnancy. And so specifically more to speak on that, during pregnancy, a patient has a greater increase in plasma volume than red blood cells, which causes this physiologic anemia of pregnancy. Pregnancy is also a hypercoagulable state, and it includes many changes, including venous stasis and decreased circulation time, increased clotting factors, so like factor 7, factor 8, factor 9, and factor 10, in addition to fibrinogen. There's a decrease in factors that inhibit coagulation. There's depressed fibrinolytic activity, so that's that action that splits up or dissolves the clot. That's depressed as well. And all of these things that change during pregnancy increase a patient's risk by about 5 to 6 times for a thrombolytic or thromboembolic complication. The hypercoagulable state is meant to be a protective function. It's meant to help decrease the risk of bleeding during pregnancy, to help decrease the risk of hemorrhage in the immediate postpartum period. But it does increase our patient's risk of thrombosis, not only during pregnancy, but in the postpartum period as well. Some specific changes that occur postpartum related to blood components are the hemoglobin and hematocrit are affected. And in fact, these levels can sometimes be difficult to interpret 1 to 2 days postpartum related to the blood volume changes that we just discussed. So that fluid shift that occurs from fluid moving from the intravascular space to the extravascular space and then moving back intravascular again. Sometimes those changes can be a little bit difficult to interpret. In general, the decrease in plasma volume initially after delivery can result in hemoconcentration because that plasma is getting moved out of that vascular system to the extravascular space. And so that can have a temporary rise in hematocrit because now we have more red blood cells than plasma in the blood, that vascular space. One thing that I want you just to remember is that with our patients that have preeclampsia or with sepsis, because of the damage in those two complications, especially that occurs to the vascular system and the blood vessel walls, it's very common for those patients to experience hemoconcentration as well because they have leaky vessels. Um, those vessels are damaged, they become leaky, and the plasma leaks into the extravascular space in those as well. And so they can also present with hemoconcentration. So sometimes in those first couple of days postpartum, this can make it tricky to interpret and determine what is the cause. Is it a normal physiologic change that's occurring, or is there a complication that's happening with your patient? So look at the full clinical picture, look at your other signs and symptoms for your patient, do some more investigation if you have concerns for preeclampsia or sepsis. You're not only going to look at the hemoglobin and hematocrit levels. So to me, that's common sense, but I just want to emphasize that. And then, like I mentioned, about 3 days postpartum, when that extravascular fluid goes back to the intravascular space, then we might have a little bit of hemodilution that occurs temporarily. And then hemoglobin and hematocrit should reach non-pregnant levels by about 4 to 8 weeks postpartum. White blood cell count during labor, they can rise to about 30,000, excuse me, during labor and after delivery. And we also may see, so this increase in white blood cell count can occur without the presence of infection. So don't be surprised if your patients, when they're coming to you in the postpartum period, excuse me, have an increase in white blood cell count. This is a pretty common occurrence. It should return to non-pregnant levels by 1 to 2 weeks postpartum. However, this can obscure the diagnosis of acute infection. So generally speaking, what's recommended is that if you're looking at white blood cell count, you've had an increase or a spike and it's changing, or it continues to trend and continues to increase, any change of more than 30% in a 6-hour time period may be indicative of infection. And that's just a general guideline. So again, same with your hemoglobin and hematocrit. When looking at hemoconcentration, you really need to look at the full clinical picture for your patient in regards to infection, not just the white blood cell count. Does she have a fever? Does she have other signs and symptoms? And organs being involved, et cetera? Those are things that you need to investigate further on and not just rely on that one lab value. Other blood components that are affected during the postpartum period, clotting factors and fibrinogen are affected as well. So the hypercoagulable state from pregnancy that we talked about in a previous slide, this remains elevated in the immediate postpartum period, and it increases your patient's risk of thrombus formation and pulmonary embolism for about 12 weeks postpartum. This risk is further exacerbated by an increase in the diameter of the deep veins that happens during pregnancy. That takes about 6 weeks to go back to normal as well. And so that just exacerbates the risk for thrombus formation. Changes that happen with the platelets, these are initially decreased as a result of placental separation. They come back and increase by about 3 to 4 days postpartum, and then those platelet levels should return to a non-pregnant levels by about 6 weeks postpartum. Things that you would be assessing for in your patient when you're doing your cardiac assessment are listed on this slide for you here. So after delivery, the heart does return to its normal position as uterine involution occurs. So you'll be able to listen in the same place that you would for a non-pregnant patient. When you're assessing for perfusion, you want to make sure that you look at the heart rate, that you're doing blood pressure assessments, evaluating pulses. What is your patient's oxygen saturation? That you're looking at their capillary refill, et cetera. You want to evaluate if they have presence of chest pain. Do they have any heart palpitations? Do they have any neck vein distension that's present? Are there any arrhythmias that you're hearing or noticing? Do they have any edema? And what kind of edema is it? Is it dependent? Is it non-dependent? Where is it located? Is it getting worse? Is it improving? Is it new? When did it start? When did it increase in severity, et cetera? And then one thing to note too with our patients, because of that significant decrease in cardiac output after delivery, Our patients sometimes can experience orthostatic hypotension, and they have a risk for that for several hours after delivery. So just a side note, because of those changes that are occurring in the cardiac system, and that risk for orthostatic hypotension, you want to make sure that you're assisting your patients in getting up to the bathroom or up in the room for several hours after delivery. When you're doing your cardiac assessment too, most of the time providers have evaluated this, but don't assume that they have. It's always a good idea to ask your patients to verify. But it is helpful to know if your patients had a history of cardiac disease, such as congenital heart disease, valvular disease, rheumatic heart disease, coronary artery disease, etc. This will let you know if your patient's at increased risk for cardiac decompensation and more complications after delivery. This history of heart disease, it puts your patient at risk of not being able to compensate for the changes that occur during pregnancy and then in the postpartum period, those drastic changes to the cardiac system. You want to educate your patients to call a healthcare provider if they have any heart palpitations or racing heart. So racing heart is kind of the easy way that I like, or the terminology that I like to use for patients, that they can easily understand. If they have any sudden or worsening swelling in their face, hands, or legs, do they have any chest pain? Do they have any chest pressure? Any difficulty breathing or shortness of breath? Those would all be reasons to call 911 or to be seen in the emergency department. If you're asking them or telling them, especially about the swelling, I would say one thing that I try and emphasize with my patients too is that the swelling can be especially concerning if they wake up in the morning. And so I try and teach them, like, what pitting edema is. Are they able to push on that affected area? Does it leave a dent in their skin and take time to disappear? And if they have pitting edema, if that's occurring, they need to let their provider know. Looking at the respiratory system for our patients, we'll talk about some changes that occur during pregnancy and then compare that to the postpartum period. So during pregnancy, there are increased oxygen demand and consumption needs that occur to support that growing fetus, the placenta, and changes in the maternal organs. Oxygen consumption increases about 20 to 40% during pregnancy. Pregnancy-related dyspnea is common. It's thought to be a result from increased effort of inspiratory muscles, and it can increase during late pregnancy from mechanical pressures. We should not see difficulty breathing or dyspnea in the postpartum period because it's related, again, mostly at the end of pregnancy to those mechanical pressures and that growing fetus and uterus. So if you're seeing this, excuse me, in the postpartum period, red flag. Another thing that can be really helpful is, as a nurse, is to be able to differentiate between physiologic and pathologic dyspnea. So dyspnea that's caused, or for example, like dyspnea that's caused by cardiac decompensation would be pathologic. So physiologic dyspnea is mild, it's not progressive, it does not interfere with activities of daily living, and it does not occur at rest. And we talk about signs and symptoms here in a little bit. When doing cardiac and respiratory assessments for patients, you'll hear me mention those signs and symptoms. Pregnancy is a state of compensated respiratory alkalosis. This occurs as progesterone increases the sensitivity of respiratory center receptors. So for patients that are pregnant, their PO2 increases, their PaCO2 decreases, they have a base excess and serum bicarb decrease, and the pH increases slightly. The purpose for that is so that there can be transfer of CO2 from the fetus to the mother, and transfer of O2 from the mother to the fetus. So if you think about in science class, those processes of diffusion that you learned forever ago, this is where we're seeing it in action in the body during pregnancy. In the postpartum period, there's an immediate decrease in intra-abdominal pressure, which allows for greater expansion of the diaphragm so that baby has been delivered. We're not having that pressure from that growing uterus and baby on the diaphragm. And so they can finally take that nice deep breath again because of that expansion that's allowed. There also is decreased diaphragmatic pressure and pulmonary blood flow that increases chest wall compliance for our patients. There is a rise in partial pressure carbon dioxide levels due to that decrease in progesterone and removal of the placenta. We no longer need to transport carbon dioxide from the fetus and oxygen back to the fetus again. So as soon as that placenta delivers and that progesterone drops, then that carbon dioxide starts to rise. There is an oxygen debt from labor that extends into the postpartum period. So your patients do have increased oxygen needs, kind of similar to those that maybe would have just done a strenuous exercise or after you work out in a strenuous manner, and how your body needs extra oxygen. This is similar to our patients after they've gone through the second stage of labor. It does vary depending on the length and the severity of their second stage of labor, but they do generally have that increase in oxygen needs. So it's important that your patients maintain oxygen saturations at 95% or greater, just like they should during pregnancy. So when you're doing your respiratory assessment, you'll want to auscultate the lungs. Breath should be clear for your patient. Any diminished breath sounds can indicate a PE or maybe asthma or some other respiratory complications. So note that if you hear it. Any crackles or rales on auscultation can indicate possible fluid overload or pulmonary edema in your patients and need further investigation. Look for signs and symptoms of the above. So diminished breath sounds, crackles and rales. If those are present in addition to chest pain, tachycardia, anxiety, that may indicate a pulmonary embolism and requires further investigation. You also should monitor your oxygen saturations and your patient's respiratory rate and their depth. So there you're looking at oxygenation and ventilation. You also want to monitor the level of consciousness, and remember that pulse oximetry and apnea monitors, those are only adjuncts to the nursing assessment. They're not sensitive to hypercarbia or hypoventilation. And so you actually need to be going in and listening to your patient's respiratory rate, counting it manually, and observing for the depth of their ventilation as well. You should assess for the risk of central nervous system depression related to opioid use if your patient's receiving opioids for pain control in the postpartum period, or if they receive neuraxial morphine, such as like Duramorph during delivery. We see this sometimes with C-section patients. Duramorph specifically, it has a long duration of action, approximately 12 to 24 hours or so. And so your patients really need to be monitored more closely because they are at higher risk for respiratory depression. There can be early onset respiratory depression related to opioid use and administration, and late onset. So early onset would be for patients that they experience respiratory depression less than 2 hours after administration. Late onset would be if they experience it greater than 2 hours after administration. So you always want to have supplemental oxygen, your reversal agents available, and respiratory support equipment available for any of your patients that are receiving opioids for postpartum pain or that receive Duramorph or neuraxial morphine during delivery. Your antidote, we should know this, hopefully, is Narcan or naloxone. The typical dose would be anywhere from 0.4 milligrams to 2 milligrams IV. You can also give it IM or sub-Q. One thing to note is that Narcan's duration is typically shorter than most opioids, so you do want to be alert for rebound opioid depression if you are needing to administer that in your postpartum patient. Other things that you would want to ask your patients, are they experiencing any difficulty breathing, any shortness of breath? Do they have orthopnea or any difficulty breathing when they're laying down? Are they having to sleep like propped with pillows in order to help them breathe better? Do they have a cough? If they do, what kind of cough is it? Is it productive? Is it non-productive? Is it dry? Is it wet? Is it a new onset cough, or have they had it for several weeks during their pregnancy and now into the postpartum period? Or has it just started in the last couple days or in the last day or so? All these things are important to know and to investigate. A cough plus difficulty breathing when laying down plus difficulty breathing in general is indicative of cardiomyopathy and needs further investigation, along with other signs and symptoms that your patient will be having. You want to educate your patient specific to the respiratory system to call their provider if they have any difficulty breathing or shortness of breath. Again, this is similar to the cardiac. Heart palpitations or racing heart, chest pain, persistent cough, unable to breathe while lying down. These are all typically an emergency, and they would need to call 911 or be seen in an emergency department. Moving on to the endocrine system. So we'll talk about placental hormones, pituitary hormones, and metabolic changes that occur. So during pregnancy, their enlargement of the thyroid gland and increased production of thyroid hormones occurs. T3 and T4 levels and basal metabolic rate increases during pregnancy. We see an increase in estrogen and progesterone during pregnancy. Pituitary gland increases in size from the increase in prolactin producing cells that are in preparation for lactation during pregnancy. There's increased insulin needs that occur for a pregnant patient because those hormones during pregnancy act as insulin antagonists to help ensure that the fetus receives adequate glucose supplies during pregnancy. We see that beta cells of the pancreas grow in size and they multiply to increase insulin production during pregnancy as well. Sometimes pancreas cells, those can become stressed to meet insulin demands during pregnancy, and then this can result in insulin deficiency and then ultimately development of gestational diabetes. So placental hormones after delivery significantly drop because of removal of that placenta, which makes sense, right? This causes that dramatic decrease in the hormones that are produced during pregnancy. Estrogen and progesterone levels drop significantly after birth. It takes about a week for them to go back down to their lowest point in the postpartum period. Estrogen decrease is correlated with diuresis of extracellular fluid. And we talked about that in the cardiovascular system. And so this decrease in estrogen helps to excrete and remove that fluid that's been shifted from intravascular to extravascular in those first few days postpartum. Reverse diabetogenic effects of pregnancy due to that decrease in human placental lactogen, estrogens, cortisol, and placental enzyme insulase occurs after delivery as well. So because of this, we can see significantly lower blood glucose levels in the immediate postpartum period for our patients. Postpartum patients with type 1 diabetes will likely need significantly less insulin for multiple days after birth, especially if they're breastfeeding, because it prolongs these effects that we see after birth. Changes that occur within the pituitary hormones, there is prolactin levels are highest in the first month postpartum in a breastfeeding patient, and then they gradually decrease after about 6 weeks, but they remain higher than that of a non-breastfeeding patient. Prolactin levels are significantly influenced by breastfeeding, including infant suckling, nipple stimulation, frequency and duration of breastfeeding, the use of supplementary feedings, and strength and infant sucking stimulus. In non-breastfeeding patients, prolactin levels decline right after birth, and they will reach non-pregnant levels by about 3 weeks postpartum. Oxytocin is produced by the posterior pituitary in response to infant suckling or nipple stimulation with milk expression. Oxytocin triggers a milk ejection reflex, moving milk from the alveoli in the breast where it's produced all the way down to the nipple so the baby can transfer to baby. There are metabolic changes that occur in the postpartum period as well. So basal metabolic rate, this is part of thyroid changes that occur. That remains elevated for about 1 to 2 weeks postpartum. It can contribute to sweating in addition to diuresis after birth. And so you'll see this very commonly with postpartum patients. They sweat a lot. We do a lot of sheet changes when I take care of patients, a lot of bed changes because that sweating is really common, and you can just assure them it's a normal thing. It's how their body is trying to get rid of that extra blood volume and fluid that was accumulated during pregnancy. Thyroid levels or the thyroid gland will return to non-pregnant state by about 3 months postpartum. Patients do have an increased risk for transient autoimmune thyroiditis in the postpartum period. This is a destructive autoimmune disease that can occur in the first year after delivery in a woman that doesn't have any history of thyroid disease before pregnancy. It can cause transient or permanent thyroid disease. The thing with the thyroid that's important to note is that it affects breastfeeding. And so if you have a patient that has untreated hypothyroidism, it can affect milk production and their ability to transfer milk to their baby and to breastfeed successfully. So this would be something that patients would need to watch for, and then they would hopefully see a provider if they're experiencing signs and symptoms. Typically, what will happen, signs and symptoms that your patient would experience might be anxiety, insomnia, heart palpitations, fatigue, weight gain, irritability, weight loss or irritability, or so that would be symptoms of hyperthyroidism, or they also may have symptoms of hypothyroidism, such as fatigue, weight gain, constipation, dry skin, depression, poor exercise tolerance, etc. So any of those changes would be something to educate your patient and have them notify their provider for further investigation. Moving on to the urinary system, we'll talk about renal function, fluid loss, and the urethra and bladder changes that occur during the postpartum period. So during pregnancy, there are many structural and functional changes that occur to the urinary system. Lots of these will carry on into the postpartum period. So it's important that we talk about them. During pregnancy, there's enlargement of the kidneys, the ureters dilate, they undergo hyperplasia and hypertrophy, and the muscle tone of the ureters relax. A urinary stasis occurs from changes to the ureters and associated slower urine rate. This increases the risk for urinary tract infections both during pregnancy and in the postpartum period. During pregnancy, there is decreased bladder tone, which increases bladder capacity and increases the risk for infection even further. We see increased renal function, which occurs from pregnancy hormones, increase in blood volume, patient's posture, their physical activity, and their nutritional intake as well. Glomerular filtration rate increases, and this results in an increase in creatinine clearance, decrease in serum creatinine, decrease in blood urea nitrogen, and decrease in uric acid levels. Patients during pregnancy experience an increase in total body water of 6.5 to 8 liters from increased maternal blood volume. Water, the content of the fetus, the placenta, the amniotic fluid, also from intracellular fluid in the uterus and the breast, extravascular fluid, and increase in adipose tissue. That is a lot of water increase during pregnancy. Glycosuria and proteinuria may occur as well during pregnancy. So for glycosuria, normally the kidneys will absorb glucose from the plasma filtrate. However, in pregnant women, tubular reabsorption of glucose is impaired, causing glycosuria. And so this can normally be seen in pregnancy. However, if it is present, gestational diabetes needs to be considered and it needs to be ruled out before glycosuria can be determined to be transient. Proteinuria can occur because of an increase in urinary excretion of protein and albumin that happens normally during pregnancy. So again, while proteinuria may be transient, it can also be associated with complications such as preeclampsia, so we would need some further investigation. Looking at the postpartum period in contrast, decreased steroid levels after birth can contribute to reduced renal function for our postpartum patients. We expect that spontaneous voiding should return in about 6 to 8 hours postpartum. There are hormone changes that occur during pregnancy, like we mentioned, that affect your patient's postpartum. So decreased steroid levels after birth, those can contribute to reduced renal function after delivery. It takes about 6 weeks for that to go back to its normal level. Ureters return to non-pregnant state about 8 weeks postpartum. So remember that during pregnancy, they're dilated, they have poor tone, and they increase the risk of UTIs in the postpartum period. That increased risk of UTI is even higher during the postpartum period because of tissue trauma from labor and birth, effects of epidural analgesia or anesthesia, or perineal or vaginal discomfort. And then if you have patients that experience postpartum, or when they experience postpartum diuresis, that can cause bladder overdistension as well because of that relaxed bladder tone that patients have, an increased bladder capacity. Once patients start to diurese, all that extra fluid that they've developed during pregnancy, if they're not emptying their bladder frequently, they are at high risk for bladder distension and for UTIs as well. Blood urea nitrogen levels increase postpartum because of the autolysis that occurs with the uterine involvement that we talked about at the very beginning of this presentation. Ketonuria can occur in patients with uncomplicated deliveries or after a prolonged labor if they experience dehydration. So that's something to note as well. Within 12 hours after delivery, postpartum patients begin to excess tissue that was accumulated during pregnancy. So remember those multiple liters of extra fluid that we talked about. This fluid loss is because of decreased estrogen, in addition to removal of increased venous pressure from the lower extremities, and then the loss of the remaining increased blood volume from pregnancy that we talked about in the cardiac section. Urine output of 3,000 milliliters or more each day for 2 to 3 days postpartum is expected for your patients. They have to be able to diurese and get rid of that extra fluid that's been moved from in the intravascular space to the extravascular space, and all that extra fluid that was accumulated during pregnancy. You might see an increase in diuresis and urine output for patients that have gestational hypertension, preeclampsia, and diabetes as well. Your patients can experience profuse diaphoresis, so that sweating, like I mentioned, for 2 to 3 days postpartum, especially at night. So that's something to note as well. And that's just one of the compensatory mechanisms that helps to excrete that extra fluid. Fluid loss from perspiration and diuresis in the early postpartum period accounts for weight loss of approximately 5 to 7 pounds. So that's a lot of fluid that's being removed. In contrast, if your patient is not diuresing, is not excreting that fluid, that is a lot of fluid to retain. That puts a significantly higher workload on the heart in the postpartum period, and it puts them at risk for cardiac decompensation even more. Looking at the urethra and the bladder, patients in the postpartum period can experience a decrease in void urge, which may occur from birth-related trauma, increased bladder capacity at birth, and effects of anesthesia. They can have reduced or altered void reflex, which can occur from the result of pelvic soreness from delivery, they might have vaginal or perineal lacerations, or they might have an episiotomy. All those can affect the void reflex for patients. They may experience increased risk of bladder distension from decreased voiding or postpartum diuresis. Other things that can increase their risk of bladder distension include if they've received epidural anesthesia, if they had an episiotomy, extensive vaginal or perineal lacerations, if they were a forceps or a vacuum-assisted delivery, and if they had experienced prolonged labor. If your patient had an indwelling catheter, they also may experience difficulty voiding for the first time in the postpartum period. In the early postpartum period, there is a significant risk for uterine atony and hemorrhage. This distended bladder will push up on the uterus, moving it over to the side, like we talked about earlier, and prevent it from contracting normally. So it's important that your patients are voiding consistently and you're evaluating that they're able to empty their bladder completely. There also is an increased risk of stress incontinence that patients can experience in the postpartum period. This can be related to tissue trauma or from the pelvic floor that occurred while they're pushing during delivery. It may have occurred from forceps-assisted delivery or birth of a large baby. When you're doing your urinary assessment, you should be looking at, your patient's eyes and nose, like I mentioned earlier. So we have all of that fluid that needs to be excreted, in addition to any fluid that we've administered to that patient during labor and the postpartum period as well. So just remember Their baseline for what they should be diuresing is about 3,000 milliliters a day for 2 to 3 days postpartum. That does not include any additional fluid from IV administration or other medications that we have administered to that patient. That would increase their diuresis need even further. So it's really important that you watch their eyes and nose. Look at their urine characteristics, look at their voiding pattern and amount. Are they able to void spontaneously? Can they empty their bladder completely? Do they have any bladder distension? Is dysuria present? Have they had an increased, have you needed to catheterize them to empty that bladder? Or do you need to straight cath them to empty that bladder? So those would be things to evaluate for. Other considerations in the postpartum period related to the urinary system. If you have a patient that has an indwelling catheter, we see this typically with our cesarean section patients. It is ideal to have it removed by 8 to 12 hours or sooner when the patient's able to get up and ambulate to the bathroom. So the sooner that we can remove those, the better. 8 to 12 hours is an average, but some techs even say 6 hours. So it just kind of depends. Use your unit's protocol, use your institution's protocol. But generally speaking, the earlier the better. We want to get those patients up. We want to get them moving. We want to be able to help that bladder be able to respond in the postpartum period, to be able to empty appropriately. You should avoid bladder distension with your patients. A distended bladder, again, is the most common cause of uterine atony. So prevention of hemorrhage is significantly related to bladder distension and your patient's ability to void and empty. Techniques that can help with a patient if they're having difficulty spontaneously voiding could be you having them listen to running water while they're going to the bathroom. Placing their hands in warm water sometimes can help. I'll sometimes fill up a peri bottle with warm water and have them measure the amount that's in the peri bottle for sure, so I can accurately continue to monitor my eyes and nose. But fill that peri bottle up with some warm water and have them rinse their perineum before they go to the bathroom. Sometimes that will help them relax and be able to void. A warm shower can help. Other relaxation techniques such as deep breathing. I've had some nurses that swear by whistling on the toilet, or sitting backwards, or just different things that they have tried that they think that has helped. But a lot of those are just relaxation or distraction techniques. It also may help to pre-medicate your patient before you get them up to the bathroom. Pain medication can help prevent reflux spasms of that urethra and because of response to pain. So especially if they have a laceration, if they've had some vaginal trauma, and they are anticipating that it is going to hurt when they void, giving them pain medication ahead of time can help prevent that spasm of the urethra in response to pain. And then on this slide too, it just has indications for insertion of a straight catheter. You would do straight cath your patient if they have a distended bladder and they're unable to void. If they're just voiding small amounts frequently, so less than 100 milliliters or so, and then no void within 8 hours postpartum. You want to teach your patients before they discharge from the hospital on peri-bottle use, hand hygiene before and after when they do peri-care, to wipe the from front to back. Don't assume that your patients know this. It's always a good reminder to change their peri-pad often, to void every 2 to 4 hours, to increase their clear fluid intake, and to avoid caffeinated beverages. Remember that your patients are at higher risk for a UTI. That postpartum bladder is the perfect environment for a UTI because of trauma from delivery, bacteria that could have been introduced during delivery and labor, from multiple cervical exams, catheterization, retention of residual urine, all sorts of things. And so teaching your patients to call their provider if they have signs and symptoms of a UTI is really important. So do they have urinary frequency, urgency, hesitancy, pain with urination, dribbling? Are they having to go frequently during the night? Do they have suprapubic pain? Any blood in their urine? Does the urine have an odor or a smell? All of those things would be things to have them call their provider for. Moving on to the gastrointestinal system. During pregnancy, patients have decreased muscle tone, mobility, and gastric emptying time, which increases the incidence of constipation. Normal bowel elimination will resume in the postpartum period about 2 to 3 days postpartum. Patients can experience decreased gastrointestinal muscle tone and mobility and motility. And this is present from pregnancy and from labor, and it can persist into that immediate postpartum period. They may have, if they have a delay in spontaneous bowel movements, it's typically related to this decrease in tone and motility. Patients also may, let's see, they may have a risk of postpartum anal incontinence that occurs in the postpartum period, especially if they had a pelvic floor muscle injury from birth, or if they had a 3rd or 4th degree laceration involving the anal sphincter. So when you're doing your gastrointestinal assessments, you want to palpate the abdomen. Is it soft? Is it firm? Is it distended? What does it feel like? You want to listen to their bowel sounds. Does your patient have bowel sounds present in all 4 quadrants? If so, are they hypoactive? Are they hyperactive? What are you listening to? What are you hearing? And then lastly, ask your patient, are they nauseous? Do they have any vomiting? When was their last bowel movement? Are they passing any gas? What is their appetite like? Again, remembering that their normal bowel movement pattern, it should resume in about 2 to 3 days postpartum. It would be abnormal for your patient to have no bowel movement by day 4 postpartum, any constipation, any diarrhea. And so those would need some further investigation or treatment. There are different things that we can do treatment-wise, pharmacologic and non-pharmacologic, for nausea and vomiting for our patients. Non-pharmacological treatments you could try would be cold therapy, so cool washcloth, using a fan can really help. There's different inhalation techniques like essential oils. So if your institution may have like they're like little essential oil pods that they can smell that would help decrease nausea. You could try any of those things. Sometimes even an alcohol wipe, and having them smell an alcohol wipe is an old trick that we used to use on the floor as well. The pharmacological interventions that you may give to your patients might include administration of medications such as Zofran or Phenergan or Reglan. Gas pain interventions can be really helpful to know. Gas buildup is a problem for a lot of patients in the postpartum period, especially if they've had a cesarean birth, because of the anesthesia that was administered and then the intestinal manipulation that has occurred during the delivery process and during surgery. So doing these interventions that are listed here can be really effective. Number one, I would say most important, ambulate early and often. Get your patients up as soon as possible. Start walking, teaching them the importance of ambulation and why it's effective is really important. Chewing gum can be really helpful, especially before your patients are able to eat after surgery. So having them start chewing gum can help stimulate the gastric motility, wake up that GI system to help prevent gas buildup. They can try rocking in a rocking chair. They can try heat therapy, especially with that cesarean, that manipulation that's occurred. Sometimes our patients will experience like referred gas pain up to the right shoulder. And so putting a heat pad on that area as well can be really helpful. You can teach them to try avoid gaseous foods, and there are medications that they can try as well, such as simethicone, if those non-pharmacological interventions are not effective. Interventions to help facilitate return of normal bowel function for your patients in the postpartum period include eating a high fiber diet, having adequate intake of fluids, so drinking lots of water to thirst, making sure they don't ignore the urge to go. Sometimes patients can really have fear, like true fear or worry related to that first bowel movement, especially if they've had some vaginal trauma or if they have hemorrhoids after delivery. And so teaching them things that they can do ahead of time to avoid constipation, and also teaching them not to ignore the urge to go, even if they might have a little bit of concern or worry, is really important. They should avoid straining when they're trying to have a bowel movement. They should ambulate early and often. Daily stool softeners can really help prevent constipation. They should be using their hemorrhoid medications or interventions that we talked about earlier if those are present, and avoid use or overuse of narcotics because those obviously increase the patient's risk for constipation. One thing that I wanted to note too is if your patient had a 3rd or 4th degree laceration, nothing should be placed in the rectum for those patients, including suppositories or enemas. They can increase significantly their risk of bleeding and infection. And so doing those things, especially for those patients to prevent constipation and to promote bowel motility, is really important. They would need to be taught to call their provider. Patients in the postpartum period need to be taught to call their provider if they do not have a bowel movement by about 3 to 4 days postpartum, or if they have any concerns for constipation or inability to pass a stool. Moving on to the integumentary system, I'm not going to read through these, but they're just here for your benefit, for your interest. So on the left-hand side are changes that occur during pregnancy. And on the right-hand side are when those changes resolve in the postpartum period. So cesarean sections or incisions, so as we're kind of moving down the different systems, when we're assessing for wound healing in response to cesarean sections, you should be looking at the type of incision that your patient has. Note that they will have a uterine muscle incision and a skin incision, and those may be the same or they may be different. And it can be depending on, excuse me, on delivery mode, how difficult delivery was, what history they have previously of surgeries, etc. So we assess for the type of incision, the closure type. So do they have sutures, staples, steri-strips? Do they have adhesive on there? Do they have skin adhesive? Do they have a Provena? Do they have a Prineo? How is that incision closed? We'll look at healing of that cesarean section incision. Is any redness present, edema, bruising, discharge? Is it approximated? All things that are important to evaluate. Look at the surrounding skin. Is it red? Is it itchy? Is there a rash present? Is that skin moist? It can be common for patients, I would say, to have some irritation from the adhesive, from a dressing, especially if that was covering that incision immediately after the cesarean section. And so just evaluating that surrounding skin is important as well. Here's some examples of cesarean section incision closures. So you can see what stitches or staples externally would look like, steri-strips. Your patient may have insorb staples or insorb sutures. Those dissolve on their own. They're inside or underneath the skin. They may have a Provena, which is this top one. It looks like a wound vac almost. Those can be especially helpful for our patients that have maybe a pannus, where some wound healing or moisture may be of concern. And so this can really help decrease that, keep that incision nice and dry, and prevent the risk of dehiscement and infection for our patients. Incision care that you would want to teach your patients. They need to keep their incision clean and dry. They can shower as usual, but they should not submerge their incision in a bath. They need to keep it dry, like I mentioned. So after they shower, they should pat that incision just very gently with a clean cloth, or allow it to air dry. Sometimes I'll tell my patients, as you're getting out of the shower, when you're getting ready for the day, if you're pulling on your postpartum undies, just roll them down underneath that incision and let it air dry while you're getting ready. Interdry can also be used to keep that incision nice and dry, and I'll show you what that looks like here just in the next slide. If they have steri-strips present, they should allow them to fall off spontaneously. They should not take them off like a bandage. So allowing them to fall off spontaneously is really important, and teaching them to do that. Staples are typically removed the day of discharge for our patients, so you may be the one to take those out to assess the approximation of their incision afterwards. It's not uncommon when we remove staples from an incision that we apply steri-strips after if there's any spaces or any gaps in that incision that look like it maybe wouldn't remain approximated. If your patient has a Provena or a Prineo, those will stay in place during the postpartum period. Typically, the provider will remove those at a postpartum visit that is scheduled in the first week or two after delivery. InterDry is a really great product that helps prevent infection and keeps incisions dry after delivery. I really like it. So I have a slide here on this because I think it's really effective. We have these available in the facility that I work. We have this available in our postpartum units. It is a moisture wicking fabric. It helps the skin stay dry. It eliminates friction. There is antimicrobial silver that is in InterDry, which helps fight itching from the incision and odor causing bacteria. You would have your patient wash their skin and pat it dry before applying the InterDry. You just put a single layer on their incision, allowing about 2 inches of fabric exposed on either side for moisture evaporation. They can use this for up to 5 days, which is why I really like it. So you can send them home with a new piece of InterDry, and it would be good for 5 days when they're home. It can be really helpful for patients that have, like I mentioned, any concerns with moisture. If they have a larger pannus and airflow has a difficult time getting to that area, it can decrease their risk of infection and breakdown on that incision site. When you're assessing your patient's incision, you want to assess for infection and hematoma. And so this little table just gives you an example of what those look like and the comparison between the two. Hematoma is typically pronounced edema. It's fullness, it's firm. Patients will have a lot of times bruising, significant pain associated with it, versus infection typically is red. There might be edema, some drainage, bruising. They may not have an approximated incision. And usually, I mean, not always, but typically with the hematoma, it's earlier onset in the postpartum period, and infection is a later onset. You should educate your patients to call their provider when they're home if they have any signs of infection, including a temperature greater than or equal to 100.4, any foul-smelling vaginal or incisional blood or discharge, increased redness or pus from an incision, episiotomy, or laceration, and any concern for something that is not healing. Musculoskeletal changes that occur during pregnancy, mostly everything relaxes and stretches and loses tone. That abdominal wall can be relaxed for a couple weeks after delivery in the postpartum period, and it can take about 6 weeks for it to return to its pre-pregnant state. Return of that muscle tone, it does vary based on previous tone for your patients. Are they exercising? How much adipose tissue is present, etc. There is relaxation and hypermobility of the joints that occurs during pregnancy, and that takes about 6 to 8 weeks to stabilize in the postpartum period as well. If your patient experienced back pain during pregnancy, that usually resolves in weeks to months after birth. All joints should return back to their pre-pregnant state, except for the feet, which don't return to a pre-pregnant state. So just a fun fact for you, but some postpartum patients can notice a permanent increase in shoe size because of those joints that have relaxed and don't return back to their state before they were pregnant. Restless leg syndrome is common during pregnancy. So if your patient experienced this, you can assure them that it will subside in a few weeks postpartum, not immediately, but it will get better over the weeks after delivery. When you're doing your assessment of your lower extremities, you should assess your patient's legs for any redness, any warmth, any tenderness. We're looking for blood clots here because of that risk of VTE that we talked about, that thromboembolism risk for our patients. Is there any edema present? Is it bilateral? Is it unilateral? If you have any concerns at all that maybe the edema is in one leg more than the other, you can measure. Use your calf circumference or your leg circumference, measure and compare bilaterally for your patients. You can start at the thigh, get measurements on both the left and the right side, and go down to the ankle and compare. If there is a 2 centimeter or greater difference that exists between one leg and the other, that's considered clinically significant and can be a sign for thrombus formation. You should also, when you're doing your lower extremities assessment, you should also be assessing your patient's DTRs and for a presence of clonus related to, we do those neurological assessments, especially for our patients who are at risk for preeclampsia and other neurologic conditions. All postpartum women are at risk of developing thromboembolism factors, which include that hypercoagulability that we talked about. If they have severe anemia, that puts them at risk. If they're obese, if they had a traumatic delivery, if they have a history of cesarean section, and if they are receiving magnesium in the postpartum period, that also increases their risk. I have a slide on the Holman sign, but I do want you to know that while the Holman sign was traditionally used in postpartum assessments, it is no longer really common practice to assess for potential presence of a thrombus formation or a clot in the leg. And the evidence on the accuracy of the Holman sign is really contradictory. It's not diagnostic. Some people, and the thought process is that it can lead to increased risk for a dislodged clot or an embolism by dorsiflexing that foot. And so you may work in an institution where you still do the Holman sign. If so, here's some information on that. But do note that it's really not common practice. It's not evidence-based practice any longer because of its lack of diagnostic ability. Interventions when you're for the lower legs would include ambulation. I can't emphasize this enough. Having your patient ambulate early and often is really, really important, whether they're a vaginal delivery or a cesarean delivery. Obviously, for cesarean patients, there are increased risk for a clot formation, but our vaginal delivery patients still have the same physiologic changes that increase that risk as well. So ambulating early and often for both patients is really important. If you have a patient that is confined to bed or has maybe is a fresh C-section, has not gotten up yet, teaching them to do some leg exercises in bed can be really helpful. They also may apply or anti-embolism stockings or sequential devices may be applicable for those patients. It's also recommended, the anti-embolism stockings are also recommended for patients with varicosities. Sequential devices can be used or recommended for patients that need to be in bed for a long time or prolonged time after delivery. So this would patients, those that are receiving maybe magnesium sulfate administration and maybe feeling ill or unable to get out of bed as often as if they weren't receiving those medications. If a patient is resting in bed or whether they're sitting in a chair, you want to have them avoid pressure behind their knees, any prolonged sitting, crossing of their legs, as that decreases blood flow and it encourages stasis of the blood and clotting potentially. You'll want to have them elevate their legs while sitting if that is an option, and then encouraging them to stay hydrated as well. And then you also want to teach them to call their provider if they have any red or swelling in their legs, especially if it's in one leg and not the other, if it's painful to the touch and if it's warm to the touch. That could be a sign that they have developed a blood clot and they need to notify their provider. Okay, moving on to the neurological system. Headaches are a common finding in the postpartum period, but they do require careful assessment. So they may be caused by postpartum onset preeclampsia. They could be caused by stress, leakage of cerebral spinal fluid from an epidural or spinal anesthesia. They may be caused by fluid shifts after delivery, fluid or electrolyte imbalances, or resumption of pre-pregnancy migraines, excuse me. Experiencing headaches should be carefully assessed to rule out maternal complications. So don't assume that it is a benign finding or if it's a low risk finding. Do your good assessments, further investigation to rule out complications. Cognitive changes can occur in the postpartum period from fatigue, sleep deprivation, changes that are happening with progesterone and estrogen after delivery. And so for our patients, this can result in decreased attention and concentration, decreased memory, And remember, as I mentioned at the very beginning of this presentation, there's a lot of education that we give to families, signs and symptoms to watch for, when to call their provider, self-care. And so for your patients, because of these cognitive changes in the postpartum period, they will need lots of reinforcement of education. Printed handouts are helpful as well, but you should be teaching it multiple times in different ways, and also involving a support person or other family members in that education as well. Carpal tunnel from pregnancy oftentimes is relieved as the median nerve compression disappears with elimination of increased fluid retention from pregnancy. When you're doing your neurological assessments for your patients, you should be looking at their level of consciousness. Do they have any headaches, any dizziness, any syncope, or any visual disturbances present? Do they have any floaters? Are they seeing any spots or sparkles? Do they have any ringing in their ears? What are their reflexes? And evaluate their DTRs, deep tendon reflexes, and then evaluate for the presence of clonus. You'll teach them to educate or to call their provider, excuse me, if they have a headache that does not get better or go away, even after rest, hydration, or over-the-counter medication. Any vision changes or disturbances, any changes in level of consciousness, they're probably not going to notice that. That's going to be like a partner or a family member that would notice that, or a seizure. All of these require evaluation soon. So to call 911 or to go to the emergency room. Just a little note on a spinal headache or post-dural puncture headache. These are more common with epidurals versus spinal patients. It can be spinal fluid from that puncture of the dura mater. And patients with that may experience this, they can have signs and symptoms that begin about within 2 days after delivery, and it can persist for days or weeks if it's not treated. Usually our patients will have severe headaches. Sometimes they can have ringing of the ears, sometimes they can have visual disturbances, but typically it's that severe headache, and it's classic telltale sign when your patient can lay down flat and the headache will resolve, or they will feel much better. And when they sit up or stand, it becomes significant and intense, and they're unable to do activities of daily living for some patients. That is the classic sign. Laying down, the headache goes away, and sitting up or standing, it triggers that severe headache. And that's because assuming an upright position triggers a change in the volume of the cerebral spinal fluid, and it increases leaking of that fluid. So that's why that happens with our patients. There's conservative treatment that can be done if your patient's experiencing a spinal headache. We can try oral analgesia. Sometimes I've called anesthesia and they've said to try caffeine intake. So having the patient drink Red Bulls or coffee or soda, any of those things to see if that helps. Bed rest can help too, but it's challenging if you have a new baby, you're breastfeeding, etc. So if that conservative treatment either doesn't work or a patient doesn't want to go that avenue, then a blood patch can be a reliable method. And a blood patch is basically when just like 20 milliliters of a patient's blood, it's injected slowly into their lumbar epidural space. Their own blood creates a blood clot in that space, and it patches that dura mater. It prevents leakage of that cerebral spinal fluid. Patients usually do very well after receiving a blood patch, and they improve much faster. When you're doing your neuromuscular assessments, you should be assessing the lower extremities for strength and sensation, especially if your patients received anesthesia, epidural, or a spinal anesthesia. Remember to assist them with ambulation because of that risk of orthostatic hypotension that occurs in the immediate postpartum period. That risk lasts for about 48 hours or so, but typically we'll see patients that experience it. We'll see it the first few times that they get up to the bathroom. So making sure that they're calling you before they get out of bed so that you can be there and present to help them and assess for that is really important. Some patients will experience postpartum chills right after delivery. I mean, it can happen with any vaginal delivery or cesarean patient. Neither one really increases the risk more. But this is our patients that in bed, I mean, they're just like shaking with chills. And it can be hard to get at vital signs. It can be hard to get at blood pressure. It is a benign finding, but it can occur after delivery. There's a few theories on why it happens. Some people think it's from a sudden release of pressure on the pelvic nerves after delivery. Some people think it's a response to um, the fetus to mother transfusion that occurs during placental separation. Some people think it's from an adrenaline production during labor and birth, and then some people think it's a reaction to the epidural anesthesia. Regardless, there are a few things that have actually been shown to be effective in literature to help your patients if they experience this. So having them apply a warm blanket or putting a warm blanket around them, you can kind of wrap them up really nice and tight, have them take nice deep breaths. And that can be helpful to resolving those chills or those shakes. Once those shakes come back, if they return, you can reapply a warm blanket, go through that with them again, and remind them to relax their shoulders as much as possible too. And that should help it resolve. Immune system, just a few notes. Immune system suppression occurs during pregnancy. It gradually resolves in the postpartum period, and the time it takes for it to return to normal is unclear. So we don't have a ton of data to show when does it actually return to its normal state. But we know that both pregnant and postpartum patients are at risk for infection because of this immune suppression. There is an exacerbation of autoimmune conditions that can occur and be triggered by rebound of the immune system in the postpartum period. So sometimes if you have patients that have an autoimmune condition, sometimes those, because of that immune suppressed state, patients will feel better during pregnancy. Examples of this might be if they have MS or arthritis or lupus or even migraines sometimes can get better too, but that's not an autoimmune condition. But anyways, so they may experience a suppression of those signs and symptoms related to their disorder. And then in the postpartum period, once the immune system is back again, it's not suppressed any longer, they can actually have rebound of worsening symptoms. So preparing for that in the postpartum period can be really helpful. It is important that we really work on infection prevention for our patients in the postpartum period because of their increased risk of infection in multiple areas. Lacerations, episiotomies, from in the uterus and the cervix, from different interventions that were done during labor, from the bladder, relaxed muscle tone, all sorts of different areas. We need to teach them to do effective hand hygiene. You should be doing that as well as the postpartum nurse, teaching them to facilitate complete bladder emptying. So like measuring every time that they're going to the bathroom, monitoring those I's and O's really closely, letting them know what an accurate volume is, that they should be getting up routinely to go to the bathroom and not waiting, because sometimes that trigger to go may not happen until that bladder is too full. Assess breastfeeding to ensure that they have proper technique, adequate emptying and prevention of nipple trauma to decrease the risk of infection in the breast and the nipple, and then teaching them again, proper maternal breast and perineal hygiene is really important as well. And we've touched on that earlier in this presentation. But remember that the most effective and the least expensive treatment of postpartum infection is prevention. So doing those really good education, teaching your patients to do those different interventions that will decrease the risk of infection is really, really important. You can provide anticipatory teaching before patients go home on preventative measures for infection, what signs and symptoms to watch for, and when to call their provider, including a temperature of greater than or equal to 100.4, signs of that RETA that we talked about, the redness, erythema, redness, ecchymosis, edema, drainage, and approximation. Do they have any foul odor associated with a laceration, an episiotomy, with their incision? Do they have any flu-like symptoms? Are they having increased pain, etc.? They would need to call their provider for those. When you're doing a pain assessment, you guys should know this, but you need to look at the intensity, the quality, the location. Are there any radiating elements? What's the duration and onset of the pain? Does anything make it worse? Does anything make it better? What's the impact on your patient? How does it affect their activities of daily living, etc.? Pain, common complaints of discomfort for your postpartum patients would be related to their perineum, so laceration or episiotomy, or even just swelling. Hemorrhoids can cause pain. They may have after pains, like we talked about with that uterine contraction. They also may have muscle strain related to delivery position, etc. There are non-pharmacological interventions that you can do that are really effective. These would include heat application, ice. We talked about the ice diapers earlier, ambulation, repositioning, use of sitz baths. All of those things can really help with the non-pharmacological side of things. There are some topical agents that would be considered pharmacological, such as dermaplast spray or Tux pads that can be really effective too. And then typically for our postpartum patients, we are moving away from routine narcotics because of the opioid crisis and trending towards scheduled NSAIDs and Tylenol. In fact, alternating those scheduled to help decrease pain for our patients. So most of your postpartum patients, unless there's an allergy or a reason to avoid, they will receive ibuprofen or Motrin, 800 milligrams every 8 hours routinely around the clock. If I have a patient that says, oh, my pain is, I don't really have much pain. I don't feel like I need the ibuprofen. I do educate them. Clearly they can choose to refuse it, but I do educate them on the ibuprofen. The NSAIDs have an anti-inflammatory effect as well, in addition to the decreasing the pain. And so there's some inflammation that will happen in their breasts as they have changes that occur during the postpartum period. There can be inflammation in other parts of their body, and so the ibuprofen can really help decrease or treat engorgement or that physiologic breast fullness that occurs after delivery. And so there's multiple purposes for it just beyond pain. But going back to that routinely, all postpartum patients, unless there's a contraindication, would receive ibuprofen, 800 milligrams every 8 hours. And then a lot of times for our cesarean section patients, we have begun starting to alternate with scheduled Tylenol or acetaminophen, 650 milligrams every 4 to 6 hours. Or, excuse me, 1,000 milligrams every 8 hours. This has been really effective and demonstrated in literature to decrease the need for opioid use in our cesarean section patients. So they would receive ibuprofen, and then a lot of times it would be 4 hours later acetaminophen, and then 4 hours later ibuprofen. I know there are some facilities that administer them at the same time. So you would follow your institution's protocol, obviously, for that. But that can be really effective in decreasing opioid use, which has multiple benefits, including decreased risk for constipation with your patients. Now we're going to move into the more of like the emotional side of things, energy, rest, emotions, and in your assessments that you should be doing with patients. So having a new baby can bring both joy and it can bring challenges for families. Becoming a new parent creates a period of change and instability for any parent who chooses to raise a child. This period of change includes a process of role attainment and role transition that happens over the first months postpartum. As a mother's learning to adapt to her new role, she's learning to restructure her relationships with her partner, with her other family members. She's learning to develop an attachment with her baby, to gain competence in mothering tasks and behaviors, and to find fulfillment from interacting with her baby. There are a couple theories. So Rubin's theory of maternal role attainment is now, Mercer has kind of taken that and adapted it to now becoming a mother theory, or the BAM theory. This helps describe this process that occurs in the transition to motherhood a little bit more clearly. So there's some stages that happen in this process. And Mercer defines that the process is by which a woman is learning motherly behaviors. She becomes comfortable and confident with her identity as a mother. She becomes attached to her infant and expresses pleasure and gratification in her new role. Typically, new mothers will progress through a series of developmental stages as they adapt to their new role. And Rubin focused on the first weeks postpartum, whereas Mercer looked more at a wider time period up to 1 year postpartum. There's 2 of Rubin's stages, which are similar to Mercer's second and third stage, which include the taking in stage and the taking hold stage. These are things that the taking in stage is something that you likely will see and observe. You may see the transition to taking hold stage as well, but you'll see this in the postpartum time period. So the initial taking in stage usually lasts about 1 to 2 days postpartum. And during this time, typically mothers are passive, they're more dependent, they're more preoccupied with their own needs, such as food and sleep and hygiene, showering, etc. They may need to talk or debrief about labor and delivery experiences, and a lot of times they'll ask questions. In the taking hold stage, this begins after that initial taking in stage, and it can last for about 4 to 5 weeks. So you'll see this more towards the end, like more towards discharge of your postpartum patients. During this phase, a mother resumes control of her body and control of mothering. She focuses on the needs of her baby in addition to her own physical needs. She's interested in learning to care for her baby. She may be worried about her mothering techniques, so breastfeeding technique, diaper changes, bathing, etc. She may experience more fatigue and increased infant demands as well. Lastly, there are some things that can influence a mother or a parent's transition to their maternal role. And some of these, so there, it's important to know what risk factors exist in your patient that can impair this transition to becoming a mother. Maternal factors such as prolonged labor, use of medications during labor, type of delivery, and any complications at the time of delivery are risk factors that may be present. There could be newborn factors present, such as gestational age, admission to the NICU, separation of mom and baby, or congenital anomalies. There may be socioeconomic factors present, including economic resources and degree of maternal support. Family factors may be present, including demands and needs of other children in the family, quality of relationship between both parents and their social support that exists. Maternal age and parity are risk factors, as well as if she's experienced any challenges with her mothering role previously. And finally, there may be some challenges related to role conflict with a career. So mothers oftentimes will have challenges adjusting to their new role and conflicting demands with their baby, their family, and their job. Assessing your patient's transition to becoming a mother is really important for both maternal mental health and for assessing bonding with her baby. So if you're having any concerns about your patient's risk for failure to assume their mothering role, for example, if they're an adolescent patient, if they have poor social support, if they don't demonstrate care or interest in caring for their baby, if they if you're seeing any of those things, then I would say you definitely should be advocating for closer follow-up by their OB provider and their pediatric providers after discharge, as well as community health follow-up, so those home health visits, if that's possible. Bonding is defined as the emotions and feelings experienced by the mother or other parent in relation to the infant, whereas attachment is a two-way interaction between the mother and the baby that develops in the first year of life. So bonding occurs before attachment. Bonding is what you're going to be seeing and assessing for in the postpartum period. The quality of attachment's not typically assessed until about 9 months of age. So we'll talk about how to assess for bonding a little bit and how to facilitate bonding in your patients. This is really important for a healthy parent-infant relationship and for long-term development of a baby. It's also important when evaluating maternal mental health to look at the bonding component. Bonding occurs during early processes where parents are becoming acquainted with their baby and through mutually satisfying experiences between parents and babies. It begins during pregnancy and it continues to develop into childhood. Rooming in of between mom and baby couplets, it provides greater opportunities to observe for interactions between mom and for baby and to note any positive or negative bonding behaviors that you might see in your patients on the postpartum unit. The examples listed here on this slide can help you with the assessment of bonding behaviors in the immediate postpartum period. When a baby is brought to parents, there's things that you can ask for or assess for. So when the baby is brought to the parents, do they reach out for the baby? Do they call the baby by name? Do the parents identify features about their baby, such as who they resemble or what appears special about their baby? When parents are holding their baby, what kind of body contact do you observe? Do they seem like at ease, like it's more natural? Do they seem at ease in changing their baby's position? Do they use their whole hands or do they just use their fingertips? Do they avoid touching certain parts of their baby's body, or are there parts of the body they scrutinize or investigate? When the baby's awake, what kind of stimulation do parents provide? Do they talk to their baby? Do they talk to each other? Do they talk to no one? Is it quiet? Are they constantly on a device and not interacting? How do they look at their baby? Do they use visual eye contact? Do they avoid eye contact? Or do they look at other people or objects instead of their baby? How comfortable is the mom and are the parents when caring for their baby? Do they express any concerns about their abilities? Do they express disgust for certain activities such as changing the diaper, etc.? What type of affection do parents exhibit to the baby? Are they smiling, stroking, kissing, rocking? If their baby's fussy, what comforting techniques do the parents use? Do they try rocking, swaddling, talking, or stroking? These are all things that can really help you in assessing bonding between mom and baby while your patients are on the postpartum unit. And then there's things that you can do to facilitate bonding. So skin to skin for the first hour postpartum and continue as much as possible in that postpartum period before families go home is really helpful in facilitating bonding. Postponing eye prophylaxis for 1 hour after delivery to facilitate eye contact between mom and baby when that baby is most awake after delivery can be helpful. You can encourage moms to tell of their birth story, and you can provide clarification to information as needed, but talking about that story can really help facilitate that bonding experience. Not separating moms and babies as much as possible is very effective. Try and do as much uh, with that baby while they're skin to skin as possible, especially in the first hour to 2 hours after delivery, but encouraging that continued skin to skin and non-separation in the continued postpartum period is really important as well. This includes rooming in. So rooming in is where moms and babies are staying together. We're not separating baby to go to the nursery for sleep. It really helps promote educational opportunities. Parents learn about babies' sleep-wake cycles. They are able to breastfeed more effectively, which is what we see in literature. It increases their confidence in caring for their baby. All of those things. And studies also have shown that rooming in does not decrease the amount of sleep that parents get. So there is a thought that if the parent sends the baby to the nursery, that they would get more sleep. And studies have shown that babies who are sent to the nursery, those parents really do not on average get any more sleep than if the baby were to stay in the room. You can also include parents in cares and assessments and planning while they're on the postpartum unit. Try and give them choices as much as possible. Allow them to do as many cares as possible with their baby. One big one that I feel like is really important on the postpartum unit that I try and incorporate families in is the bath. So not really demonstrating that first bath, but incorporating parents, bringing them in, teaching them, having them do the hands-on with that newborn bath is really effective. Creating awareness of and responsiveness to the newborn. You can teach parents to observe for newborn cues, how to respond to those cues. And then lastly, don't forget about family bonding and significant others and siblings. How can you include them in that bonding process that you're facilitating while your patients are on the postpartum unit? Looking at energy and emotions, each mother should be evaluated at different times to determine if she's having a difficult time bonding with her baby or if she maybe is just really tired and having a lot of fatigue. You should be aware as the postpartum nurse of perinatal mood and anxiety disorders concerning signs and symptoms, and when you need to call the provider or notify the provider on information regarding bonding, energy, emotions regarding your patients. There are a lot of facilities that routinely assess for postpartum depression and anxiety using the Edinburgh Postnatal Depression Scale or the EPDS scale prior to discharge from the hospital. And so this can be a really helpful tool to alert you and the healthcare team of concerns maybe specific to depression, anxiety, in the immediate postpartum period. As a postpartum nurse, you should help promote rest and activity with your patients. Promoting rest is really effective as sleep loss, feeling stressed, and physical exhaustion are the top three problems that patients experience in the first 2 months after birth. Also to note, disrupted sleep is a trigger for postpartum depression and anxiety. So it's really important to ensure that your patients are comfortable, that you're meeting their needs for rest and sleep by clustering cares for both mom and baby and encouraging limited visitors as much as possible. Your patient's activity can gradually increase over the postpartum period after discharge. You can teach them that light exercise can be resumed at about 2 weeks if they don't have any complications, and then they can move more towards vigorous exercise by about 6 weeks postpartum. You want to discourage them from driving if they're taking any narcotics. And then sexual activity, the old recommendations were that couples were discouraged from having sexual intercourse until 6 weeks after delivery. But we now know that healing is individual. And so specific to just the perineum, that takes about 3 to 6 weeks to heal postpartum, but couples may choose to wait longer for sexual intercourse for other reasons, due to body image or baby's needs or maternal sleep deprivation, decreased libido from those hormone changes that are happening, vaginal dryness from breastfeeding, etc. So really this needs to be an individualized conversation with providers in the postpartum follow-up visit. Related to nutrition and health, you want to encourage your patients to have a healthy, well-balanced diet after discharge. Do consider cultural preferences. So there are some cultures that prefer cold things rather than warm things after birth, and then vice versa, warm rather than cold after birth. And this includes foods and liquids. There are some cultures that eat a certain diet after delivery. They believe that it helps facilitate postpartum healing and that transition. And so being sensitive to your patients and asking if there's any specific preferences that they have is really important. You can provide dietary counseling related to breastfeeding, constipation, anemia, etc. We talked about a lot of these, increasing fluids, increasing fiber intake, to help decrease those risks in the postpartum period. If a patient is breastfeeding, they need about an additional 500 calories per day. There are no restricted foods, so they can continue to eat what they were eating before and just watch their baby closely for any reaction that they may have. Every baby is individualized. And they should also continue to take a multivitamin or a prenatal supplement while they're breastfeeding as well. There are some common immunizations that may be administered during the postpartum period. The first is the Tdap vaccine, or tetanus, diphtheria, and pertussis. Typically, this is administered during pregnancy around 27 to 30 weeks gestation. It's given early in pregnancy to maximize the maternal antibody response and passive antibody transfer from mom to the fetus before delivery. However, it may be administered to postpartum women who have not previously received the vaccine. So if you have a patient who did not receive the Tdap vaccine during her most recent pregnancy, but Anne has not previously received the vaccine at all, then she may be a candidate for to receive the Tdap vaccine in the postpartum time period. You also may be administering influenza vaccines if that's in the season in which your patient delivered. The MMR immunization is also administered if your patient's rubella non-immune or equivocal. This is a live virus, so you should be teaching your patients to avoid pregnancy for 28 days or 4 weeks after administration, because it does have potential teratogenic risk to a future fetus, to a future pregnancy. Patients who are immunocompromised should not receive the MMR vaccine because the virus is shed in urine and other bodily fluids. And it's also important to note that the live virus in the MMR is not communicable in breast milk, so it would be appropriate to administer that to a breastfeeding patient. You should, administering the MMR vaccine in conjunction with RhoGAM can interfere with the desired immune response for the MMR vaccine. So RhoGAM suppresses, and we'll talk about RhoGAM in a second, but it suppresses the immune response and it can interfere with any live virus immunization, such as the MMR. So it may be helpful if you have a patient that needs both of these to administer the RhoGAM in the postpartum period and either have your patient receive the MMR at a postpartum follow-up visit, or if they received both in the hospital, they would need further testing, a post-vaccination serology test in about 3 months postpartum to verify their immunity. RhoGAM is indicated for when you have an Rh negative mother who gives birth to an Rh positive infant. And what this does is it prevents sensitization in Rh negative mother by preventing production of anti-Rh antibodies after exposure to a baby that has Rh positive blood. We administer this within about 72 hours postpartum. Typically, you'll need a workup to determine what the dose is, and that's based on exposure that a mom has had to with these antibodies and the volume that she has in her system. Usually, the dose is about 300 micrograms, but it goes up anywhere from there: 300, 600, 900, 1200. This could be administered via IV push or intramuscularly, and it protects against erythroblastosis fetalis, or the hemolytic disease of the newborn. We've talked about a lot of changes within the maternal system that occur during pregnancy and postpartum. Vital signs kind of help wrap up those changes. So when we look at our vital signs for our patients, you might see some changes to temperature. So a temperature may increase in the first 24 hours postpartum, but it should not excess or increase to above 100.4. Patients should be afebrile after 24 hours. There is a thought that low-grade fever is not uncommon in the first 24 hours postpartum related to exertion during labor, potential dehydration that your patient may experience. And so really look at closely that 100.4 or greater. That would be your sign or an indication for infection in the first 24 hours or continued thereafter. Doesn't mean that your patient doesn't have infection if their temperature is lower than 100.4. It just means that you need to look at their whole clinical picture and not that isolated sign and symptom. Pulse can remain elevated for approximately 1 hour postpartum. So remember that pulses increase by 15 to 20 beats above baseline during pregnancy. It can remain elevated for about an hour in the postpartum period. And then it should gradually decrease over the first 48 hours postpartum to go back to its normal baseline. It is not uncommon for patients to experience puerperal bradycardia, where that heart rate can potentially decrease to 40 to 50 beats per minute. This can be common for 6 to 8 days postpartum, and it's thought to be related to a decrease in the cardiac strain, decreased blood volume following that placental separation, and increase in stroke volume. Respirations after delivery, the diaphragm descends, the normal cardiac axis is restored, the point of maximal impulse and EKG changes are normalized, and respiration should be at baseline after birth. Blood pressure changes. There may be about a 5% transient increase that can occur during the first 4 days postpartum. If that happens, it should return to its pre-pregnancy levels within weeks to months in the postpartum period. Do remember that your patients are at increased risk for orthostatic hypotension related to increased blood flow and fluid accumulation that can occur in the abdominal organs, and that rapid shift that we have in fluid after delivery. So they need to be monitored more closely. And then lastly, oxygen saturations. Because of that increase in oxygen demand, especially after labor, saturations should remain at greater than or equal to 95%. This slide will show you, so on the left-hand side are the normal postpartum vital sign ranges that we would expect to see for patients. And on the right-hand side, it will show you some abnormal changes and potential causes that may be related to that change that your patient is experiencing. So I'm not going to read through all these with you, but just know that they're here for your reference. So for example, if your patient has a pulse, if they're tachycardic, we know that their pulse should be anywhere from 50 to 90 beats per minute. So if they're tachycardic, then they may be experiencing It could be related to pain, fever, dehydration, hemorrhage, infection, sepsis, cardiovascular disease, etc. So this will give you some kind of ideas of what to investigate if they're experiencing these signs and symptoms. As we wrap up, I just have some tips for you for your postpartum assessments, to be consistent and to do a good job and to ensure that you are accurately assessing what you need to with your patients. One is to identify risk factors. You should be aware of risk factors that increase your patient's likelihood for postpartum complications. Use this knowledge when you're completing your assessment of your postpartum patient to be alert for complications associated with risk factors that are present on prenatal history and delivery history. There are a variety of examples that I could provide to you, but just one would be, if your patient has a history of, let's say, trying to think of a good one, cesarean section. You would know that they're at increased risk for increased healing needs, increased pain, infection, thromboembolism, length of stay, impaired or delayed breastfeeding. Those would be examples of some things. So when I'm assuming care for a postpartum patient, I do take time to look through the prenatal document and to glance through it, and also to observe and listen for complications that have happened during delivery. And I just take little mental notes, check marks, of things that maybe would be red flags or could cause complications in the postpartum period. And that helps me as I monitor my patients and do additional assessments. It is important to choose the appropriate time for completing your postpartum assessment. Make sure that your patient, if they're in pain, do they have pain medications due soon? Have they emptied their bladder? Do they need to breastfeed their baby? Is their baby crying and causing some stress? Like, find the time that's appropriate and coordinate that well with your patient. I encourage you to perform a full head to toe assessment every time with every patient. Not all facilities require a full head to toe assessment for patients, especially if they're low risk and vaginal delivery. However, my problem with this is that if you, as a postpartum nurse, are not doing consistent assessments with your patients and getting really good at assessing the normal findings for your patients, when you have one that presents with abnormal, it's going to be harder for you to identify those. You won't have a baseline to go off of and compare to. And so in my experience, doing a full head to toe assessment every time is most effective. And then I know at the beginning of on my patient's admission or the beginning of my shift, what my patient's lung sounds were. Did they have a cough present? I'm evaluating and assessing all those things. So if something changes before discharge, I've got something to compare to. I have a baseline that I've created. I also encourage you to explain assessment components with your patients. Use the time of your assessment to start your education. Teach your patients what you're watching for. I literally, as I do my head to toe, I go down every system. I ask patients, for example, with neurological, are you experiencing any headaches, dizziness, bringing up the ears, seeing any spots? And if they say no, they'll say, great. I want you to know, though, if you do experience those when you go home, that can be a sign that your blood pressure has increased to a dangerously high level, and you need to be seen by your provider. You need to call your provider right away. And so that's kind of how I go through. I'll ask my questions, I'll do my assessment, and then I explain to the patient why I'm assessing for those things. That way, when they go home, I'm giving them their discharge education. It's not a surprise. They've heard it multiple times from me before. Find your method and be consistent. So that will just help with that routine, that muscle memory, so you don't forget things. Staying organized is really effective, documenting in real time. And then, like I mentioned, incorporating your discharge education early and often. Assessment frequency really is going to vary based on your patient's delivery process, what kind of anesthesia that they've had, did they have any presence of complications or risk factors that we knew about before delivery or after. But in general, the very basic baseline is that your patients should have postpartum vital signs and a postpartum assessment at least every 15 minutes for the first hour postpartum. at least every 30 minutes for the second hour postpartum, and at least every 4 hours for 12 to 24 hours postpartum. We'll obviously do these more frequently if we have complications that we've assessed for with our patients, but this is just a general guideline. However, you do need to refer to your institution policies and procedures on when to do these more specifically and what items they should entail. These are some examples of postpartum organizational tools that I created that I use when I'm on the floor. The left is for a new cesarean section, and the right is for either a cesarean section that's over well past their hourly vitals and assessments, or vaginal delivery as well. So these are just some examples of things that you can do to help stay organized. Charting the computer is great, but when I go to call a provider, or if I catch a provider in the hallway and I have a question, I want my papers that I can whip out and just have everything that I need right in front of me. So I use this for myself because I'm a paper person, in addition to electronic medical record. You do not have to, but these are some examples of things that have been really helpful for me. And making sure that I'm getting a full head to toe assessment, looking at all my risk factors, and I also don't miss my assessments that are coming up or medications. Postpartum discharge education. So during your patient's postpartum stay and in preparation for discharge, you really need to be assessing for the mother's physical and psychological condition, whether any concerns or complications have been addressed. If what your patient's overall adjustment is to becoming parents and to being a family, new family, and if there's any need for outside resources for your patients. As you perform your assessments and provide education to families throughout their stay, you should be assessing their knowledge, their expectations, their beliefs, providing anticipatory guidance and education based on all those assessment findings. Prior to discharge, there are some basic things that need to be met. Your patient should have normal vital signs. They should have appropriate involution of the uterus. They should have appropriate lochia amount and characteristics, knowledge of signs of infection, appropriate incision, laceration, or episiotomy assessment findings, the ability to perform peri-care and comfort measures for perinatal pain, ability to void and pass gas, ability to eat and drink without difficulty, ability to care for themselves and for their babies, well-controlled pain, and an appropriate mobility level. That's like the basic information, and it's still a lot. I've emphasized often throughout this program that education is one of the primary responsibilities that you will have as a postpartum nurse. And so remembering that the discharge education that you provide to patients must begin early and often in order for it to be effective. Topics that you'll educate your patients on include warning signs. We've gone through all of those system by system. Also, you'll teach on information regarding maternal and infant care, physical and psychological signs and symptoms that they need to watch for, nutrition, exercise, sexual intercourse and activity, medications that they're taking and why, and when to follow up with their provider after discharge. Early recognition of maternal complications is critical. Patients need consistent, comprehensive, and evidence-based discharge instructions before they leave from the hospital. Evidence has shown that women who can recognize signs and symptoms and understand explanations offered for those signs and symptoms are more likely to respond to concerning symptoms and comply with prescribed treatment in the postpartum period. And likewise, providers or nurses who consistently explain signs and symptoms to patients are more likely to respond appropriately when a postpartum patient presents with those concerning signs and symptoms. So doing your education and teaching these things is not only helping your patient and their family members, but it's also helping you become a better postpartum nurse as well. Here are some examples of maternal warning sign education sheets that can be used for patients after discharge. And I think the left, I'm trying to see, the left I believe is from AIM, the AIM organization, but I can't see this really great on my computer. The middle one is from CDC's Hear Her campaign, and the right one is an example of the one that we use at the health system Methodist health system where I work. All of these are similar to A1 has a post-birth warning sign education as well. They all have similar signs and symptoms, but these are like the urgent warning signs where your patient needs to see their provider right away or needs to call 911 or go to the emergency room. So it's important that they have an understanding of what these signs and symptoms are, what they could be indicative of, and that they can verbalize that back to you that they would call for concerns before they go home. It's also really important to note that maternal complications that occur during pregnancy and the postpartum period can result in lifelong health risks for your patient. This is something that oftentimes gets overmissed. And so encouraging your patients to not only go to their postpartum follow-up visits, but also to see a primary care provider every year after delivery for the rest of their life is really important. This is from the CMQCC, and I really like it because it's helpful. It's very clear in demonstrating the risks that patients have long term. So you can see here on the left, if your patient had preeclampsia, they are 2 times the risk of having stroke, heart muscle damage, or blood clots, and 4 times the risk of developing high blood pressure for the rest of their life. If your patient had gestational diabetes, they're at 50% more likely to develop type 2 diabetes within 5 years after delivery. And if your patient had preterm birth and preeclampsia, they are 8-10 times higher risk of death from heart disease. The standard recommendation for postpartum follow-up was historically about 6 weeks after birth. That's what we used to say all the time. Follow up with your provider 6 in 6 weeks. Now, professional organizations agree that a one-size-fits-all discharge follow-up process is not working. We are seeing an increase in maternal mortality rates in our country, an increase in maternal mortality in the postpartum period after discharge from the hospital. And so we need to do better follow-up and assessment and care for our patients. Discharge follow-up after birth needs to be individualized. It often requires more than one visit, and it can vary based on complications that are experienced during pregnancy, delivery, and postpartum. Maternal care does not end with birth. Having a baby is one of the biggest changes a woman goes through, both physically and mentally. The 4th trimester is critical to the overall health and well-being of both mothers and their babies. We can help address our country's rising maternal mortality rates with more emphasis on the importance of postpartum care and support and resources. The initial assessment, what's clear in literature and with organizations, ACOG, et cetera, is that the initial assessment of a postpartum patient should occur within 3 weeks after delivery, where all patients should have contact with their OB provider. During this assessment, they should be able to identify any current problems or concerns that your patient is experiencing. And according to ACOG, this initial visit can be in person or it can be done via the telephone. I said that funny, via phone call. Early follow-up is warranted for complications for your patients. So early follow-up before that 3-week time period is warranted if your patients have hypertensive disorders of pregnancy, any chronic health conditions, high risk for perinatal mood disorders, and or breastfeeding difficulties. And then follow-up to that initial assessment should occur no later than 12 weeks postpartum. This should include a comprehensive evaluation assessing physical and social and psychologic aspects of your patient's health, excuse me. It should be done in person, and it will assess physical recovery after birth, sleep and fatigue, mood and emotional well-being, infant feeding and care, sexuality, birth spacing, contraception, and counseling about the importance of going to those follow-up care visits with primary care providers, especially if patients have complications including hypertension and diabetes. As many as 40% of new mothers do not attend their postpartum visit. So as a postpartum nurse, you should explain the importance of their postpartum follow-up care and remind your patients when to call their provider with concerning signs and symptoms. Before discharge, it's recommended that your postpartum follow-up appointment date and time be included in your patient's discharge instructions. If the appointment has not been made yet before your patient goes home, you need to encourage her to call her provider's office to schedule the visit before discharge. That has been shown and thought to be effective in increasing the attendance of our patients postpartum. Postpartum follow-up care is an important piece of the puzzle in preventing maternal mortality, so don't forget to include this in your discharge planning and process. Thank you so much for hanging in with me on this presentation. I know it was a little bit lengthy, but I hope that it was helpful for you in identifying and understanding the physiologic changes that occur during pregnancy, how those carry into the postpartum period, how it affects the assessments and the interventions that you are doing in the postpartum period for your patients, and how it ties into the discharge education that you're providing to families before they go home. Remember that you, as a postpartum nurse, have an opportunity to make a huge difference in the care that your patients receive, and also to potentially decrease our maternal mortality rates in our country, making a difference in patients long term for the rest of their life. If you have any questions at all, feel free to reach out to me. I can be reached at mwhoutreach@nmhs.org. That email address goes to our general outreach department, and our administrative assistant, Michelle, will connect your email with me with any questions that you have. Otherwise, I bless you guys. Thank you so much for hanging in there with me, and I hope that you have a great rest of your day.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.